Parag, welcome. Good afternoon.
It's an honor to invite all of you to the second day of the certificate course on emergency obstetrics. It was a roaring success yesterday. There were almost like 650 members joining at a particular time. The registrations are almost more than 900. Today's program will start with a welcome address by Dr. Sarita Balaram, the Secretary of ICOG. May I request Dr. Sarita to say a few words?
Thank you very much, Dr. Charmila, and I welcome you all to this special online course on emergency obstetrics. This is our second online certificate course of this year. Our first one was on PPH. This one is on emergency obstetrics. My thanks to Dr. Jaideep Tang, President Foxy, and Dr. Madhuri Patel for giving us this opportunity. To Dr. Parul Kottawala, Chairman ICOG, and to Dr. Sheila Mane, Vice Chair ICOG, and to Dr. Parag Biniwale, ICOG Chair-elect. A huge thank you and congratulations to our convener, Dr. Sneha Bhuyar, who's done a fantastic job. And as Dr. Charmila said, she has really surpassed all boundaries, and we have got over 1,000 registrations for this course. Thank you to Dr. Charmila for always being there and guiding. Dr. Supriya Jaiswal, our very, very enthusiastic and motivated convener, Dr. Monica Umardant, and the whole team who has made this thing successful, possible and successful. So without further ado, I request Dr. Sneha Bhuyar to please begin the second day's proceedings.
Yeah, thank you so
Before
much.
we go on to that,
Yes.
Sneha, one second. Before we go on to that, may I request Dr. Sarita to just elaborate on this announcement which has been made by ICOG regarding the fellowship course.
ICOG membership and fellowship is now open, and you can all apply. You can all apply through the website. The website is ICOG online org online.org, and we have going to have a convocation at the Foxy ICOG annual conference in October. So for that, the last date for application is 30th of August. There will also be another convocation in January in Mumbai, for which the last date is 31st of October. So I urge all people to please become a member and a fellow of the ICOG.
Thank you so much, Dr. Sarita. Today, the guests of honors are Dr. Lakshmi Shrikande, Dr. Sheila Mane, and Dr. Asha Bakshi. Dr. Lakshmi Shrikande does not need any introduction to this course because she's the one who gave it so much of popularity last year. And as we were talking, she has set the bar so high. And we welcome Dr. Lakshmi Shrikande to the program. The second guest of honor will be Dr. Asha Bakshi. She is the past Vice President of Foxy as well as the Secretary for ISAR. And the third guest of honor today will be Dr. Sheila Mane, Madam, who's the chairperson elect for vice chairperson for ICOG this year, and she's past vice president of Foxy. So may I request Dr. Lakshmi Shrikande to say a few words.
Thank you, Charmila. Thank you so much. I'm really feeling nostalgic and happy. Last year, it was a fantastic tenure, and we done almost 12 online certificate courses. And this chat box is looking so familiar to me. At one hand, the audience is getting restless because they want to give pre-test. And on one hand, ICOG team, they want to finish all their inauguration part in first 10 minutes because 4:10 you have to start the pre-test, neither before nor late. So I won't say anything. I'm just happy that this year ICOG online certificate course is going great guns, and wish you all happy learning.
Thank you so much, ma'am. May I request Dr. Sheila Mane, Madam, to say a few words.
Recording in progress.
Dr. Sheila Mane, Madam.
Yeah, hello.
Yes.
Good afternoon, everybody. And it's nice to see that the second day also is with very much enthusiasm. Everyone has joined, and I would like to really congratulate Dr. Sneha Bhuyar and team for starting this online certification program. And we already know that Dr. Lakshmi Shrikande is feeling nostalgic. So I congratulate once again, and I wish all the best for this certification series. And thank you all. Thank you, Charmila. Thank you, Sarita, for being there and greeting everybody and starting the program. So once again, I wish the best of luck. Thank you.
Thank you so much, ma'am. I think Dr. Asha Bakshi has not joined. So we'll go on to the review of the previous day's topics by Dr. Sneha Viewer before we go on to the pre-test.
Yes, thank you so much. A very good afternoon to each and everyone. Thank you so much, respected President Foxy, Dr. Jaideep Tank, Madam Madhuri Patel, the Secretary General Foxy, and of course, Parul Kotradawala, Sir, Chairperson ICOG, our dear friend Dr. Sarita Bhalerao, the Secretary of ICOG, and Dr. Parag Biniwale, the Chairperson-elect of ICOG, and Madam Sheila Mane, Vice Chairperson, for the opportunity to organize this much needed online certificate course on emergency obstetrics. Thanks, Dr. Charmila, for all the support. Yesterday we had 900 registrations and more than 600 members at a time online attending the sessions. So it was very, very informative, precise, with clear messages. So thanks to all the faculties for day one. We had Dr. Kasturi Tonimat talking on ruptured ectopic pregnancy, and Madam has given clear-cut messages, especially for surgical management, because it is ruptured ectopic, so there should be no dilemma. Only laparoscopy or laparotomy. How to decide? Definitely laparotomy when the patient is hemodynamically unstable and corneal rupture is suspected or diagnosed. It has to be salpingectomy as the tube is ruptured. So no conservative surgery, a very clear-cut message. We have Dr. Gorak Mandukar really giving, food for thought that if we use the SDP Justice score based on the maternal characteristics, totally free of cost, with comparable efficacy as the costlier test, why should we not use this as a routine for all our patients? And especially when you have the preventive measures of low dose aspirin and high dose calcium and vitamin D3. Madam Suchitra Pandit, the past president of Foxy, spoke on how to differentiate between hypertensive emergency and urgency, and in the absence of end organ damage. After managing the hypertensive crisis, how can we still continue the pregnancy till the baby becomes salvageable? Of course, vigilant monitoring for the mother as well as for the fetus continues, and at any point of time there is fetal or maternal jeopardy, we can go for termination. Of course, we had the Professor Dr. Girija Wagh, Vice President of Foxy, a revered teacher, thorough academician, and she has actually demonstrated everything right from the phases of convergence, post-ictal phase, and the details of management, the magnesium sulfate regime, how to assess the maximum toxicity and how to tackle. She has, taken through the case management thoroughly. Professor Muralidhar Pai, the Dean of Medical Manipal University, teacher of teachers, had hardcore academician, delivering the most valuable information about when to conceive, role of L-methylfolate. He was talking about the seizure disorders during pregnancy, other than eclampsia. So very well covered, sir, Dr. Muralidhar Pai. Professor Manju Puri, the institution herself, she has covered the acute breathlessness in pregnancy, right from the physiological breathlessness of pregnancy to the most dreaded complications, including the rare ones she has covered with quick management tips. Professor Achila Patra, she is the focused critical care expert from Safdarjung, also thrown a light on SLE flare during pregnancy, though uncommon, but a dreaded emergency. She explained the details of how to tackle the emergency along with the supportive measures, the various drugs, how to use, and also the role of ROSSA and anti-LN SSB antibodies, how it affects the offspring with the neonatal heart blocks and neonatal lupus. Immunosuppressants, azathioprine, tacrolimus, and cyclosporins, they were also, how to use during pregnancy, and how MMF is safe, and the mycyclophenolic acids, they are not. Professor Josna Suri, she talked on the management of thyroid storm, and before that she took us through the normal physiology of thyroid, the use of PTU methymethyl carbamazole, which one and when. Very clear-cut messages she gave. And yet another illustrious speaker we had, Dr. Aparna Sharma from AIMS Delhi. She talked about the venous thromboembolism, right from the risk scoring, which thromboprophylaxis, how the prophylactic and the therapeutic dosages, everything covered very well. I'm sure this has helped the postgraduates, not only the postgraduate, but the practicing obstetricians as well. So thank you so much once again, all of you, for giving us this opportunity. And I'm sure the day 2 program will also be equally good and very much useful for all the practicing obstetricians. With these few words, I hand over to Dr. Charmila for the pre-test. So much.
Thank you, Srega. Dr. Asha Madam has joined. Can I request Dr. Asha Bakshi to say a few words?
Thanks, Shamila. It's indeed nice to be in this session, which is being conducted by ICOG, and congratulations to Dr. Jaideep Nak, Dr. Parul Kurtawala, Dr. Sarita, and Sneha, all of you for conducting this course. This is a basic necessity, and I can see such topics which are so useful in our day-to-day time. So I think this is really the need of time, and I'm very proud that such courses are being conducted, and all the best. And I don't want to waste a lot of time, because I think more important is the academics. So thanks for inviting me, and wishing you a very happy learning.
Thank you so much, ma'am. So we go on to the pre-test now. Pre-test is, there will be questions for, you have to answer it in the 10 minutes. The timer will be on. It's mandatory that you attend all the post-test. So if you are not able to attend pre-test, at least attend the post-test after attending all the sessions. You need to get a 50% pass on all days to get a certificate, and attendance on all 3 days is mandatory. So attending one day and not able to attend the second day may not fetch you a certificate. So make sure that you attend on all 3 days. May we go on to the pre-test. Gauri, can you put the link and also put the timer on?
Ma'am. Yes, ma'am.
Thank you so much. The pre-test is over. The coordinator for today is Dr. Supriya Jaiswal. She is the chairperson of the Adolescent Health Committee. And Supriya, I'm handing over 7 minutes early for you. There's a plea in the chat box to finish the program on time. So we request that the chairpersons give gentle reminders so that the speakers finish on time. It's an academic course, so if it will be good if it's finished on time. Thank you so much. I hand over the session to you.
Thank you. Thank you very much, Dr. Charmila ma'am. So today is the day 2 of the certificate course. And so we start with the first session.
Sorry, Dr. Supriya, I think Dr. Parul is there. Maybe he can give his remarks before we begin, since we are ahead of time.
Yeah.
Yeah,
So
Dr.
over to you,
Parul.
Dr. Parul, sir.
Hello.
Yes.
Hello.
I'm sorry, I do not need to give any remarks. Yesterday was a great day and we had very good attendance. I see that 353 are online just now, so very soon we should cross 500. So please go ahead with the program. I do not want to
Thank you,
use
sir.
up more time into the pleasantries. Sarita must have.
Yes.
Yes, Supriya, you can start. Go ahead.
So, thank you, sir. So we begin with the first session. To chair the session, we have Dr. Rajendra Singh Pardesi, sir, as chairperson. Can I have the CV?
Yeah, Supriya, I would like to introduce sir first.
I think sir couldn't join.
Is it?
I think he is not to be seen. I am not seeing
Okay,
him.
who you introduce everybody, I will call him.
So Priya, before you introduce, let's be very brief as far as introductions are concerned, because then everything is written
Yes.
on the slide. So just one
Yes.
lines, please.
Okay, sir. So the sir sir was faculty in AOCOG 2011, and then he is a very was
Just
VP
1 or 2
Foxy.
points. Dr. Rajendra Singh Pardesi is the immediate past president of AMOX and we
Yes.
welcome him. That's all.
So we welcome him. Sir will be joining shortly. He had responded. Then Dr. Janmajay Mahapatra, who is the vice president of Foxy of this year, 2024. And he was also the chairperson, Clinical Research Committee, Foxy in 2013. So welcome, sir. Next, we have Dr. Kiran Kurpoti, sir, who is the vice president of AMOX. And he's been the ex-chairperson MTP committee of Foxy in 29 to 11. So welcome, sir. And the next chairperson is Dr. Vinita Singh. Dr. Vinita Singh was past president Patna OBGY Society, and she had been also the chairperson of Young Talent Promotion Committee of Foxy. Welcome, Vinita Di. Dr. Hafizur Rahman. He is the chairperson, he is the professor of OBGY and member ICOG Governing Council 21-23 and also 24-25. So welcome, Dr. Hafizur Rahman. So we'll start the first session. And Dr. Sneha ma'am, you want to welcome them? You are on mute, madam.
Yes, we can go ahead with the program. We don't want to disturb. Go ahead. I think I request the chairpersons to introduce the speaker. Yes.
So may I request Dr. Vinita Singh? Madam, please introduce Dr. Sarita Bhalerao, the first speaker.
I think don't worry, I've already been introduced.
Dr. Vinita Singh,
if
madam, you are on mute. Vinita, you are on mute.
Can you allow me to share my screen?
Yeah.
She'll just introduce.
Shall I introduce you, Dr. Sarita ma'am?
Of course, most welcome.
Yeah, she is secretary. Yeah, she is secretary ICOG at present, and she's a very sweet personality, what I can see, and a very dynamic Foxian. So she was governing council member ICOG, joint secretary Foxy 2017, past president AMWI Mumbai branch, chair AICC RCOG West Zone, quiz committee chairperson Foxy 2009 to 2011, and past chapter secretary IMS Mumbai. So and immediate past president, the Mumbai Obs and Gynae Society. So I welcome you, ma'am, to speak on a very important topic, that is antepartum hemorrhage because of abruptio placentae. That's a very important topic.
I think, yeah, Dr. Sarita, you can start.
So we have to
We can make it
Yeah.
on slideshow.
Yeah, I'm doing just that.
Yeah. Once again, I
Yeah.
welcome Dr. Radhika Singh Pardesi, the immediate past president of AMOX, and Dr. Kiran Kurtakoti, the president of AMOX. And we welcome you as chairperson, Dr. Vinita Singh, Dr. Hafizur Rahman as well.
Can I go ahead?
Yes, ma'am.
Please.
Can you hear me and can you see the slides?
Yes. We
Yes.
can.
So
we
I'd
can see
like
the slide.
Yeah, thank you very much, Dr. Vinita Singh, for that kind introduction. And thank you, Dr. Sneha, for inviting me to participate in this program. My topic for today is abruptio placentae. And really, I want to begin by saying expect the unexpected and then accept it as accepted, because abruptio placentae is something which can wake you up from your night's sleep and really be a very disturbing thing. So just to recapitulate, abruptio is premature separation of the placenta from the uterine attachment any time before the delivery of the fetus. It can happen preterm, it can happen near term, it can happen at term, at any stage. It can even happen in the first stage of labor. And really the management depends on whether it happens preterm, near term, 34 to 36 weeks, term more than or equal to 37 weeks. And the cardinal three symptoms of this condition are vaginal bleeding, abdominal pain, and abnormal fetal heart rate. So it's very, very interesting what is the pathophysiology. And this is really, we were taught in our residency that this is just a one-off thing, it happens suddenly. But today, our understanding has improved and we know that there is a long-standing chronic process and then there is an acute trigger. And this long-standing chronic process is thrombosis, inflammation, infection, to some extent vasculopathy, defective spiral artery modeling, placental infarcts, shallow trophoblastic invasion, release of vascular endothelium.
Sarita, it needs to be slide share. Huh? It is not slide share.
It's not.
Oh, you haven't. Huh?
Oh no, it's on not on slideshow.
Oh, it's not on slideshow. 1 second.
No.
1 second. Huh? I'm just starting to slide share again. Huh?
Yes, madam.
Yeah. Now is it fine? And I'm going to.
No, madam, no.
No. Just see now.
Yes, now you have to make it full screen, ma'am.
Okay, in my thing, it is full screen. In my screen, it is full screen. Okay, can you see now?
Yes, we can see. Yeah.
Is it on slideshow? Is it on slideshow?
No.
It's a slideshow, but not full screen.
It's not on full screen, but in my computer, it is full screen.
But again, go and click on, no? Maybe it will come again.
Okay, so now see, I'm just going into slideshow. I'm going into slideshow. Now is it okay?
No, not changing. But I think you can continue because it gets stuck. It will be stuck like that.
Yeah. I'm just trying once more. Okay, just once more. Give me a minute because anyway. 1 second. Huh? Sorry. Okay. Screen sharing has stopped. Can you allow me to share screen?
Yes, madam. We are made to
share, I think.
Just a minute. Just give me a minute. Just give me a second. Something has gone wrong with my Zoom.
Somebody is saying F5 button.
Yeah. 1 second. Huh? Just give me a minute. I'm sorry about this. Give me a minute. I was actually quite okay till I checked everything. And now it is... Sorry, something has gone wrong with this. I'm just...
Gauri, please make co-host to Sarita ma'am. She has joined. Yes, madam. Yeah, you share. Repeat.
Okay. I'm just going into slideshow and I'm slideshow. Is it fine now?
It is fine. It is fine.
Okay.
Just try to move your slide once and that should be okay, I think.
Okay, okay, fine. So I think expect.
Sarita, one
Yes.
suggestion.
Ah,
In the lower bar, you can zoom it up so this picture will become bigger. You can see plus and minus sign. You are 76%. Increase that. Just by
sorry.
the
One second.
logo of
Yeah, yeah, yeah.
slideshow, there is
Yeah. You want me to
so
go
increase
higher?
that.
No,
Yeah.
No,
but
no,
this
no.
is
I think
this is
This is
okay.
100%, slightly less.
okay.
Nay, press on the minus button slowly.
50% now. You
No,
want me
now
to
you
go,
are too small.
you want me
Just
to
press
go up?
on the plus button.
Well,
This
enough,
one,
It
this
will
one.
go slowly.
Enough.
Yes, don't jump.
Enough.
Don't jump.
Yeah, this is
Again,
okay.
plus button.
Fine, fine. This is fine.
Is this fine?
I think
Yes.
this should be fine.
100%.
You
Please
can even
continue.
remove this
Please
sidebar
continue.
on your left.
I don't know now. I can
Okay,
see everything
that's
very
okay.
clearly.
Go
Can
ahead.
you see my slides?
Yes, yes.
Yes.
I
Yeah.
think
Slide
it is
visible. It's
good
visible.
to go, Sarita. I think you
Okay, okay. So I finished this and I went to this and I said that it's a long-standing chronic process followed by an acute trigger. And what we need to understand here is before we understand the risk factors is that there is some pathophysiology in the pregnancy which predisposes them to abruptio placentae. And it is rupture of the maternal vessel then causing bleeding at the decidual placental interface. And that bleeding is then what causes detachment of the placenta. So there has to be an inciting event or as well. And
Sarita,
that,
sorry to interrupt. The slides are not moving.
no, I'm not trying to move it.
Okay, then it's
Okay, listen, now I'm moving it. Okay, it's moving. So there is has to be.
it's not moving.
No,
It's not
Sarita.
moving.
Click it double on the same slide so that you move it.
Okay, okay. So let me finish this slide, then I'll do double click. So there is some abdominal trauma, and that abdominal trauma, like rapid decompression after amniotomy or vaginal delivery of the first twin, opens the intravascular channels for thrombophilic substances. Now, can you see? Has it changed?
No, it's not moved.
Oh my God, it's not changed?
No.
Are you seeing risk factors?
Introduction and definition is there.
Okay, okay, hold on. Then something has gone wrong. I'm not able to understand what, because I am able to see everything.
हम log out करके log in करिए एक बार.
Yes.
I
yes.
have already logged out and logged in once more. I'm just trying once more to share screen. Now, can you see the slide? Introduction and definition?
Yes, seen. Yes.
Yes. Can you see the next slide? 1 second. Huh? Now I'm going to the next slide. 1 second. Now it's not going to the next. Can you see the can you see the next slide?
Yes.
Yes. Okay.
It's moving.
Can you see the next slide?
Yes. Yes.
Pathophysiology. Can you see risk factors?
Yes.
Okay. So I'm here at risk factors. I've not put it into slideshow. Do you want me to put it into slideshow?
Just try once. Maybe
It's
it
okay,
works.
Sarita, I think.
Is it in slideshow now?
No.
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 Because it is in slideshow in mine. You want me to do F5? F5. Now are you seeing that? Are you seeing it in slideshow?
No.
No.
No, but it's okay. You continue because the slides are quite visible. It's quite
Yeah,
visible.
I can't understand also what is the problem.
Just
Okay.
continue. That's
Yeah, so we have the risk factors, and the risk factors are 0.5 to 1% of all pregnancies. When we have a patient of chronic hypertension, the risk is 3 to 4-fold higher risk. In preeclampsia, the risk goes 4 to 6 higher risk. Also, gestational diabetes and GDM, there's a risk. Tobacco smoking. We know that cocaine and marijuana, though we don't see very frequently, can be risk factors. Iron deficiency anemia, folate deficiency, hyperhomocystinemia have all been implicated as risk factors for abruptio placentae. PPROM, chorioamnionitis, and oligohydramnios are also risk factors. And today there is some evidence also that mood and anxiety disorders can precipitate a patient, predispose a patient to abruptio placentae. And this is perhaps because of higher cortisol levels and because of changes in serotonin and beta endorphin. But what I'd like to all of you to focus on is that there is a 19% lower risk after folate supplementation, and that is what we can definitely modify. Now, two different spectra of the same condition. There can be acute abruption, where there is sudden vaginal bleeding, bleeding from centrally located large arteries, and these patients require urgent management. Or there can be a scenario where you have chronic abruption and you have recurrent episodes of light to moderate bleeding. This is the more insidious and the more dangerous version. This is bleeding from peripherally located smaller veins. And these are the patients who require additional fetal surveillance and timed delivery. We can't wait very long because suddenly they may have a bigger bleed. When we look at the symptoms, as I said right in the beginning, vaginal bleeding, abdominal pain, abnormal fetal heart rate are the cardinal symptoms. We need to rule out placenta previa and to rule out excessive show. In concealed abruption, there may be no overt vaginal bleeding or just small quantities of bleeding. There may be an intrauterine fetal demise, and the most dangerous is when we are dealing with a coagulopathy. But one must have a high index of suspicion, and when there is bleeding, there is rapid labor progress, there are FHR abnormalities, do think of abruptio placentae. What is the role of ultrasound? And different reports have shown that ultrasound has a sensitivity of 60 to 80%, but that means that they may miss almost 20% of abruption. The specificity is high. That means that if there is abruption on sonography, it's definitely there. But if it is not there on sonography, doesn't mean that it is not there. This is a clinical diagnosis. And the classical findings are placentomegaly, a large placenta, an intraplacental collection, as you can see here, a retroplacental collection, or a subchorionic collection, which is all spectrum of the same disease. Various scoring systems have been suggested, and one of them is this one, which is a very good scoring system where grade 0 is a small retroplacental clot, asymptomatic. In grade 1, there is no maternal or fetal distress, but there's vaginal bleeding and uterine irritability. In grade 2, there is fetal distress. And in grade 3, which is severe bleeding, we get uterine hypertonus, a hard uterus, persistent abdominal pain, maternal shock, coagulopathy, fetal distress, or death. And it's also often known as a Cuvier uterus. So let's look at the clinical management. Can you hear me? Am I audible?
Yes, madam.
Yes.
Okay, so in the clinical management, let's first look at preterm abruption. Now, in a preterm abruption, yes, one can consider outpatient or inpatient management. Corticosteroids must be given. We have to institute additional fetal surveillance, non-stress test, and biophysical profile at twice weekly or weekly. Color Doppler must be done because there is always some abnormality in the vessels which predisposes them to abruption. Evaluate other factors. Look for oligohydramnios, look for hypertension, look for diabetes. And best option is to deliver at 36 to 37 weeks, not to wait beyond that. Time is always of essence. Now, near term and term, what happens when there's an acute episode of heavy bleeding? First is always maternal stabilization followed by delivery. We have to look at the maternal vital signs, urine output, and mental status. Fetal heart monitoring is necessary. We send hemoglobin with platelets with coagulation, fibrinogen, and prothrombin time, partial thromboplastin time, PTT. We do blood group and cross match. If the patient is rhesus negative, Kleihauer-Betke test. No tocolysis is recommended. Remember, do not postpone the delivery for the steroids because the time is of essence. And here, magnesium sulfate is best only for seizure prophylaxis because we are not going to wait. We are going to deliver the patient as soon as possible. When we look at FHR patterns, the worst is marked fetal bradycardia with absent variability, and this is a pre-terminal condition. When there is fetal tachycardia, minimal or absent variability, or there are variable late or prolonged decelerations, or sinusoidal heart rate, these are also very serious things which suggest that the patient should be delivered quickly. And the tocodynamometry is important. The uterine transducer should be on the uterus. We'll find an increasing resting tone, and we'll find tetanic or high frequency, low amplitude contractions. My boss in Vadia Hospital always used to say that the severity of fetal heart rate changes corresponds with the severity of abruption. And if the abruption has caused an IUFD, then it is a very, very severe abruption. So remember that the worse the fetal heart rate changes, the more severe is the abruption. So that comes to management, and one of the cardinal signs of management is blood component therapy. We have to, the patient has bled, and we have to be see the hemoglobin, we have to see the coagulation profile and decide on the management. We give packed RBCs to improve the oxygen carrying capacity, and hemoglobin of 7 is an appropriate transfusion level. If the hemoglobin has gone below 7, yes, you need to give packed RBCs. For coagulation factors, we need to give coagulation FFP, fresh frozen plasma, coagulation factors, and fibrinogen to replenish the intravascular fluids, IV fluids like crystalloids and albumin. Cryoprecipitate for hypofibrinogenemia. Try to maintain the fibrinogen level between 50 to 100 milligram per deciliter. And in some cases, when the platelets are low, you have to give platelets where the platelet goal at least should be 50 plus. We need platelets of 50 plus, especially when we are contemplating delivering the patient. You need a platelet of at least 50 or 80 for a safe delivery. Today, there are more sophisticated methods available. Some ICUs in our country do have viscoelastic testing, which is also called thromboelastography or rotational thromboelastography. They are a more accurate measure for coagulation. You get a rapid result in 10 minutes, 15 minutes, because it analyzes the clot and it helps to tell you what appropriate corrective measure to use, either fresh frozen plasma or cryo or platelets or tranexamic acid as well. So this, if it is available, is a very interesting, a very important thing. Abruption is the most common cause of DIC in pregnancy. Low platelets, prolonged PTT, and low fibrinogen. This is the harbinger of coagulopathy. Mild reduction in a platelet count, normal or mildly reduced fibrinogen is what we see in the acute phase. By the time the PT and the PTT has been prolonged, it's a late finding and almost 50% of coagulation factors are depleted. And remember, when the depletion goes more than 50%, clinical bleeding is going to start. So these are the stages, and one should be very, very vigilant about these stages. Okay. What do you do when you have abruption with IUFD? 5 to 10% of IUFD is due to abruption. Remember, this is a severe abruption. In these patients, vaginal delivery is preferred, especially if there's a good Bishop score. We know that because of the release of prostaglandins and all, these patients progress quickly. If you can do an artificial rupture of membranes, if you can deliver them quickly, then doing vaginal delivery is the best. But if it is a patient with a previous scar, if it is a patient with a poor Bishop score, if it is then a cesarean may be indicated even for an IUFD in maternal interest. There are some long-term effects as well for the mother, and these are patients who have an increased risk of mortality from cardiovascular disease and cerebrovascular disease. And the question here is pregnancy a stress test for them? It is, because these factors, they already have underlying cardiovascular problems, and pregnancy unmasks these effects. And abruption and cardiovascular disease share similar pathways from the disruption of vascular system and hemostatic defects. So our job does not end once we deliver the patient and send the mother home. These are the patients who are at a much higher risk of even another abruption and long-term cardiovascular disease. When we look at perinatal outcomes, the biggest problem is preterm delivery, fetal growth restriction, and there is a 6 to 10-fold increased risk of cerebral palsy in these patients, which is very, very unfortunate. What about the recurrence risks? With one abruption, there is a 10-fold increase in the risk of recurrence. With two abruptions, there's a 25-fold increased risk of abruption, and therefore we have to be very vigilant. And finally, I'd like to say that it is a multidisciplinary teamwork, and with a whole team and with good anticipation, we will be able to achieve a good maternal and perinatal outcome. Thank you very much for a patient hearing.
Thank you,
Thank
Dr.
you.
Sarita ma'am, for such an elaborate talk on abruptio placentae, and you've dealt, I think, almost all the points related to it. And really, it's a nightmare for every obstetricians whenever there is a case of abruptio placentae. May lead to IUFT, may lead to DIC, and even the maternal death. So in this case, we should not take much more time, and we should be very vigilant, and we should, whatever we have to do it very urgently. So thank you very much.
Thank you. Thank you very much. I thank the chairperson, Dr. Vinita Singh and Dr. Sarita Madam. Now the second speaker. So may I request Dr. Janmajay Mahapatra, sir, Vice President Foxy, to kindly introduce the speaker, Dr. Basam Mukherjee. Dr. Janmajay, sir, had to leave, so he is requested. Sir, are you there?
To check beforehand, Supriya.
No,
one
he
who is
called me.
present. Yeah.
He's there. He called me just now that he has to leave, and so
Otherwise, we can have,
Hello.
somebody
Hello.
else. Yeah. Good
Yes, sir.
evening, Dr. Janmajay. Good evening. Welcome.
Good evening, everybody. Respected ICOG team, President Dr. Jaideep, Dr. Madhuri. My work is to introduce Dr. Basaf. Basaf is the past Vice President Foxy, is the medical school from CMC Belor, FIGO coordinator South Asia. One minute. FIGO coordinator South Asia Safe Abortion Committee is the clinical examiner for RCOG examination in India, member governing council ICOG 2015 to 20, honorary secretary Bengal OBG Society from 2018 to 19, young gynecological awardee EOFAG in 2011 at Taipei, past chair Family Welfare Committee Pakshi, Lady Table Vice President Pakshi 2021-22, and Organizing Secretary ICOG 2020-22. Over to Basab. He will speak on placenta previa.
Thank you, Janmajay. Thank you, Dr. Janmajay. Pleasure to be here on the ICOG forum. Yet again, thank Dr. Sneha, the convener, and the coordinators. Dr. Supriya was the one who was in touch with me, Dr. Monica Singh and Dr. Monica Umbadandara on the other side. So thank you for the invitation. I'll just move on to the presentation. It was lovely to hear Dr. Sarita. And so the next topic which we go after in the line of emergency obstetrics after the abruption is placenta previa. So placenta previa, what are the things which we need to know in a placenta previa setting? Setup is something which I'll discuss over the next 10 to 12 minutes. And I hope we have some take-home messages at the end of it all. So the placenta previa is defined as a placenta implanted partially or completely in the lower uterine segment over and adjacent to the internal os. That is what the classical definition has been, what we have studied in our postgraduate and undergraduate days. It's got an incidence of 0.5 to 1%, and it increases with the age, means the elder the gravida, the elder the patient who's pregnant, the more are the chances of placenta previa. The more the parity, if it's a second, third, fourth, more are the chances of placenta previa. And a higher birth order, that if it's twin, triplet, quadruple, then there's a higher chance of placenta previa. The proposed theories have been postulated as a dropping down theory of the placenta, defective decidua, big surface area, and persistence of chorionic activity. The associated morbidity, by what makes placenta previa very important, besides the heavy bleeding, which may happen at any point of time, which is fairly unpredictable, is also the presence of a morbidly adherent placenta, which Dr. UDP Ratnasiri will be taking after this talk. And that's so important because we talk about placenta accreta syndrome, and that is something which can definitely happen in a case of placenta previa, especially in the presence of previous scar or maybe after repeated curettage. Even the cord attachment can happen to the margin of the placenta or through the membranes, and that is a filamentous insertion. And if the vessels traverse the internal os, then we have a situation called vesa previa, which we often know is any bleeding is blood loss from the fetus, and it has been a very dangerous condition. The classic description has been low-lying. So low-lying is where the major part of the placenta is attached to the upper segment, but the lower margin encroaches to the lower segment, but not up to the os, less than 2 centimeters there. The marginal is when it touches the os, incomplete when it partially covers, and central or total when it covers the internal os even after being fully dilated. These are some pictures of the placenta, different points where we classify how we classify placenta previa. And I think we all understand that there's a migration of the placenta which takes place as the lower uterine segment forms later in gestation. And the placentas, though a lot of low-lying placenta earlier during our anomaly scans, can always change and become normally situated placenta later. So the importance of follow-up scans at least at 32 weeks, and sometimes if it's persistent at 36 weeks, is important before you classify a person that definitely they've got placenta previa, which needs intervention. So the risk factors are we had already mentioned a few, but cesarean delivery per se is a risk factor. Means if once a past history of cesarean section has an increased risk of placenta previa, and if it's a cesarean delivery with a anterior placenta previa, all of us are very concerned that that may have abnormal adherence. So increased with number of cesarean sections, the more the cesarean sections, more the chances of placenta previa. We've already mentioned age parity, multiple gestation, but there is also an association with assisted reproductive technology. So IVF pregnancy, just because it's IVF, even though it's not multiple pregnancy, can have a placenta, has a more chance of placenta previa, and maternal smoking along with that. The clinical features, we remember our old days of undergraduation and post-graduation. Vaginal bleeding, which is painless, is classically described as placenta previa. Painful, classically described as abruption, and that is something which really remains true till now. But the only thing about placenta previa is it's unpredictable, sudden in onset, and can often be recurrent. And depending on the amount of bleeding, we all know that whether you need to admit the patient, whether you can whether we can evaluate her as an outpatient will depend. So the entire idea of managing her will depend on the quantum of bleeding, whether it's affecting her hemodynamic status, what is her hemoglobin level, and elsewhere amount of a lot of other things. So general condition, generally in a case of placenta previa, because you're comparing it with placental abruption, is proportional to the visible blood loss. The reason why you're mentioning that is because in abruption, some of the blood loss may be internal, for which you will not see it outside. So it's disproportion, and that is something which goes more in the favor of that part of it, abruption, which Dr. Sarita has covered. The size of the uterus in proportion to gestational age, again, classically in abruption, you say it's larger because of the collected blood there. Uterus is classically relaxed and soft in previa, but is tense and tender usually in a case of abruption, especially if it's got a tubulae or if it's been there for a long time. Malpresentations classically are associated with previa. So if it's an engaged head, then and you're saying it's a previa, then you may not worry about normal delivery. At least the chances of a delivery are good. So usually malpresentation if the placenta occupies a lot of the lower segment where the presenting part really can't come down. Stall-worthy sign, this was a common question we used to ask in the quiz, where you press the head down, it presses on the placenta, and there is fetal bradycardia on pressure. Usually the blood bleeding in placenta previa is bright colored bleeding compared to sometimes the altered colored, which can happen in previa but is more common in abruption. So how do you confirm the diagnosis? Well, the confirmation of the diagnosis obviously is by sonography. Clinical features will give you an idea. The classical teaching, which we still have and we should continue, is that any abnormal bleeding in pregnancy, please do not do a pelvic examination first. So I think that is something which we classically tell people, because unless you have a sonography where it's sure that it's a normally situated placenta, not low-lying, then it's fine to go ahead. But otherwise, you may be tickling a placenta previa, and then you will have torrential bleeding, which will be absolutely impossible to tackle, and then you will create an emergency situation. So trans-abdominal sonography is what is normally done for everybody in an advanced stage of pregnancy first, but a transvaginal sonography also is safe. It's been proven to be safe in placenta previa, and is often the preferred imaging technique to know the location, edge, and exactly to find out whether a normal delivery or a vaginal birth is possible. So that is something which I think is important. Transperineal may also be done, and a color Doppler would give you a fair idea about the vascularity and about the abnormal vascularity, if any, which is something which may be major concern after the delivery about the amount of PPH and the bleeding which you may anticipate intrapartum and postpartum. MRI also gives you fairly clear pictures about what is important, what is necessary. Especially, you will definitely doing it if you're thinking of PAS, and I'm sure that will be covered in the next section. About clinically, we classically know that you do a pars speculum. Not always in a pars speculum you can see a placenta down from below, but at least you'll have some idea about some bogginess out there which will prevent you from doing a pelvic examination, because if you're doing that, and as I already mentioned, if it's a placenta previa, that will not be very pleasant, because you may have a situation where you have torrential bleeding and it becomes difficult to tackle. Complications, well, complications are many. Sometimes placenta abruptio is associated with placenta previa, so you may have a mixture of both, especially early pregnancy. Malpresentations we already mentioned, and premature labor is one of the complications of placenta previa, which is fairly associated with it, especially if there's a short cervix in a less than 34-week setting. During labor, yes, you can have rupture of membranes, you can have a cord prolapse, especially if it's a cord which is a velamentous insertion, or the cord which is at the edge of the placenta. There may be poor progress because your lower uterine segment is not contracting as much as it should because of the interference of the placenta there with the musculature. Intrapartum bleeding, increased chances of assisted vaginal delivery and cesarean section is something which we already know, and you must anticipate PPH, because so in case of a bleeding placenta previa, of course you'll have your normal ways in which you'll have wide bore IV cannulas start in both the lines, have your crystalloids going in one, keep your blood transfusion ready for the other one, get your blood ready, send your cross match, the normal things which we do for any bleeding patient. All that should be done in anticipation of PPH if it's not an active bleeding. But if it is an active bleeding, anyway, you need to do all that, and you get your blood and blood products ready. So the puerperium, sepsis, subinvolution, it can be expected, and embolism also is slightly higher than others. In the fetus, because of a prematurity or otherwise, there may be low birth weight, asphyxia, intrauterine death, though it's more common obviously in abruptio, not so much for placenta previa. Birth injuries, depending on if you have to really struggle to get the baby out, whether it's a section, whether it's a vaginal delivery, you may have problems. Congenital malformations, not associated with it, but can be there. So managing placenta previa, well, if you know it's a placenta previa early in your pregnancy, one of the advice which normally people give, which is of a high standard of evidence to back it, is avoiding coitus sexual activity. So that is something, but there's no really place for bed rest. So a lot of people like to put people to bed rest, but there's not much of evidence to suggest that that is useful. So bed rest per se may not be the best treatment, but at the same time, avoiding coitus is a good advice to give. Early diagnosis of nowadays we do at least 4 scans in most of the settings. You do one for dating, you do one for the NT scan or for the double marker, you do one for anomaly, and you do one for growth. So at some point of time, definitely you'll be seeing the placenta location, and that's not means unless you're working in a place where you do not have much of access to scan, but the placenta location, cervical length, these are things which need to be managed. Whenever there's an anterior placenta and whenever there's a previous section, everybody's antenna goes absolutely up and straight because you are worried about placenta accreta syndrome, and that is something spectrum, which is something which will be covered again as we keep on mentioning that, because that's a very integral part and a very delicate part and a very not much discussed part of obstetrics. No role of cervical cerclage. There were some thoughts that if you can just tie up the cervix, that you can stop the bleeding, stop the preterm labor and other things. RCOG has shown there's no role. Inform red flag signs. When do people people have to be there. In negative blood group, it becomes much more complicated. Then you may have to keep your donors ready, may have to keep blood cross-matched in some cases when it's near to delivery, and term optimization of hemoglobin from the beginning if oral hematinics work fine and well and good. Otherwise, if you want to give IV iron to boost up the hemoglobin, try to get it 12, 13 so that you have some buffer if she loses a lot of blood. Facility with blood transfusion, facility with emergency Caesar, facility with critical care, and all should be there. Antenatal corticosteroids should be offered between 34 to 36 weeks is one of the recommendations there. Conservative treatment less than 37 weeks, but most of the guidelines are suggesting delivery before 38 weeks. There are no active bleeding. You can wait. Mother is good, baby is good. We all wait and watch and just pray that no sudden bleeding, but keeping her informed about all the red flag signs where she may need to attend to the hospital in an emergency fashion. Active management, well, deliver in the unit where blood transfusion and critical care facilities are there. As we said, antenatal corticosteroids and should be given, and tocolytics if appropriate. The tocolytic discussion in the guidelines mainly is for the steroids to work. Beyond that, there's not much of mention of maintenance tocolysis to carry on the pregnancy longer. Active moderate bleeding near term, especially nobody will want to wait, and patient in labor, fetal being well assured, or it has to go, you have to go ahead. Fetal demise, congenital malformation, also there has to go ahead with an active management of delivery. Whether a section or whether a vaginal delivery is important. The cesarean section, SOGC, the Canadian guidelines show 36 to 38 weeks. Generally, in our setting also, we won't allow them to go beyond 38 if it's a planned section, if it's a placenta which is covering a fair amount of the internal loss, which will not help the presenting part to deliver. Pre-op ultrasound mapping of the placenta sometimes helpful in what type of incision you will give on the uterus. Anticipating blood loss, hysterectomy consent for PS, blood transfusion decisions in case they have objections should all be done and sorted out. And vaginal delivery based on the clinical background, women's preferences, ultrasound findings, distance from the placental edge, fetal head position, and in 11 to 20 mm distance from the internal loss, in some cases you may have a trial of labor, but otherwise you'll of course have a planned section. So the takeaway from this part of the discussion on emergency obstetrics, placenta previa in pregnancy warrants close attention and follow-up in the antenatal period. Ultrasound or MRI to rule out PAS is paramount, and I think all of us are quite aware about this because of a lot of discussion happening in academic forums over the last few years. Boosting hemoglobin during the antenatal period, arranging for blood transfusion whenever required, informed decision-making on a delivery plan are very important steps which all of us should follow and bring the patient and the relatives in the discussion and in the decision-making. Anticipating PPH is important, so once the delivery is over, don't be too happy because there may be other things to take care of, and the future risks in the subsequent pregnancies is also an important aspect which we all need to share with the patient and discuss. Thank you very much. Thank you.
Thank you. Thank you, Asaf, for your excellent and very informative talk. The prevalence of FPH in our setting is high. The major causes are abruptly placenta and placenta previa. The major fetal complications are low birth weight, asphyxia, and intermittent fetal deaths. And the major maternal complications are postpartum hemorrhage, anemia, with consequent high blood transfusion rate. Thank you again. Again, thank you to ICOG team, Dr. Sneha, Dr. Supriya, and Dr. Monica for coordinating this program. Long live ICOG, long live FOXI. Thank you all.
Thank you.
Thank you, sir. Thank you, Basav sir and Dr. Janmajay sir. So the third talk is by Dr. UDP Ratnasiri sir from Sri Lanka. And to chair the session, we have Dr. Rajendra Singh Pardesi sir. Kindly introduce the third speaker, Dr. UDP Ratnasiri sir. Rajendra Singh Pardesi sir.
Yes.
Yeah.
Good afternoon, everybody.
Good afternoon.
I would like to invite Dr. UDP Ratnasiri for his deliberation on placenta accreta. I think Dr. Ratnasiri, he doesn't need introduction to our Indians. He is the president of Sri Lankan OBGYN Society. He is chairperson of Sri Lanka International Representation Committee, RCOG. and chairperson of Maternal and Fetal Medicine Committee, AOFOC, president, is now president. So I would like to request to deliberate this talk on placenta accreta. Yes, sir.
Thank you very much for kind invitation. I think, I have to share my screen. So should I share my screen, see whether you can see my screen? Can you see my screen, please?
No, sir.
No,
Can't
sir.
you-
No.
No.
Can't see. Sorry
No,
about it.
Yes, so once again, I tell you, yeah, right now you can see your screen, but the whole screen, I think you have to minimize this window.
Can you see it now?
Yes.
Thank you very much. So first of all, thank you very much for inviting me for this ICOG session, and greetings from Sri Lanka. So my talk is on placenta accreta spectrum of disorders. I think is the obstetrician nightmare. So, but we'll see how we can manage it safely during my lecture. So in 1937, there are two surgeons, Irving and Hertage. They described this placenta accreta spectrum of disorders. Actually, they said this is a placenta invasion or something else. And it says abnormal adherence of the afterbirth in whole or in parts to the uterine wall in the partial or complete absence of decidua. So that was the first description, which was shown in 1937. The FIGO came to a classification which is mostly histopathological diagnosis with clinical diagnosis in 3 grades. And I think that is now getting obsolete because, we get histopathological diagnosis only after hysterectomy or after the surgery. But it is very important to diagnose this before our surgery to plan what we are going to do with the surgical procedure. So the alternative model is attach and spread, that says growth is by adhesions, but not invasion. It is not a cancer. It is not invading anywhere. It is just the adhesions and addition. And morbidity is driven by abnormal angiogenesis. So these two, additions and abnormal angiogenesis, are the reasons for our main problem with placenta accreta spectrum of disorders. So we have hysterectomy 90% of the time. At present, people are doing hysterectomy, but I will tell you, we can do sparing surgical techniques also with uterine sparing. And it has shown to reduce the blood loss, and it has the other advantage of reduce the maternal morbidity and mortality compared with hysterectomy. And it preserves the future fertility of women seeking children. So in my case, I usually do now simple cesarean section with uterine sparing. Over the last 2 years, I haven't done hysterectomy. So with the case load of about 165. So for this, actually, you should not attempt simply you need require highly skilled staff and restriction the application for secondary or tertiary care units with blood transfusion and other facilities. So there are several techniques which have been discussed or mentioned, leaving the placenta enclosed in the uterus that had been in the past, and then do a secondary hysterectomy. Now, friend Dr. He has mentioned triple P technique with pelvic devascularization, perioperative placental localization, and placental non-separation and myometrium excision. And combined approach, there's a combined approach described with surgical hemostasis, bilateral ligation of descending branches of uterine arteries, and hemostatic external supraplacental stitch with the use of a double balloon tamponade. So there are several methods described. So when it is a uterine sparing technique or hysterectomy, it is very important to have the preoperative preparation. So the very important placental localization and evaluation of evidence of placenta accreta spectrum with vascular mapping in ultrasound. So it is the grayscale ultrasound and the color Doppler is important, and antenatal optimization of anemia and other problems if she has other added problems, and informed written consent always when you are planning, get the consent for hysterectomy. Sometimes sterilization is also needed. The multidisciplinary team involvement. So that is a very important. So there are several members, including the obstetric anesthetists, consultants, the hematology department, and also the transfusion medicine. And better admit them early if you think the risk is more for preterm labor or rupture, and optimization has to be done prior to delivery. And preservation of blood and blood products is not only blood, and especially blood products like FFP and cryoprecipitate, and documentation of pre-operative checklist. So that is very important. So when we plan for the surgery, everything is prepared, and make sure that checklist is filled, and proper fasting prior to surgery. So this is very important. Placental localization is anomalies. So placental localization and evaluation and with vascular mapping is very important. So grayscale will show myomet. Now, if these features are present, the myometrial thinning at the previous scar site, if the thickness is less than 3 millimeter, it is called a scar defect. So that is new scar defect. And loss of retroplacental clear zone, that is obviously you all see, and a placental bulge. When you do the scan with the grayscale ultrasound, if the placenta is showing bulging into the bladder, that indicates the scar is very thin, and that is a scar defect with high risk of bleeding and abnormal lacunae. The color Doppler features includes neovascularity. So when it is neovascularity, could be seen in the uteroplacental interface, vesicular-uterine interface, and the bridging vessels joining both together, and lacuna feeding vessels. So these are the very important. So there are other things, but these are the more important ones. So this is a placental bulge. You can see the placenta is coming. The line is not straight. It is bulging. So this is thinned out. So it is insufficient myometrial tissues to support the placenta. So this bulging is very serious. When you see this during your surgery, there's high risk of bleeding because there is no living ligatures. So the uterine myometrium to control the bleeding there, unless you stitch that area with your sutures. And the AOCOC, this classification is made in the recent past ultrasound imaging protocol. So if the myometrium is thin, less than 3 millimeter, it is called a uterine window, or you can call a scar defect. And anterior placenta previa covering entire lower uterine segment within 2 centimeters of the healthy myometrium, but not reaching the internal os, it is called low-lying placenta. And placenta previa covering the cervix with a myometrial thickness of less than 1 millimeter, no additional abnormal placentation, it is placenta previa. And the other one is placenta previa with Caesarean scar defect, anterior placenta previa reaching or covering the cervix with myometrial thinning, and that is less than 1 millimeter, and placental bulge towards the bladder, and the parametria, no additional abnormal placentation site. So that is called placenta previa with Caesarean scar defect. So there is another category called high probability of placenta previa accreta. That is anterior placenta previa reaching or covering us with thinning of the myometrium less than 1 millimeter, and placental bulge towards the bladder or the parametria. And this is very important, increased uteroplacental, paracervical, intraplacental, and pelvic vascularity. So with that, there is a high risk probability of placenta accreta. Sometimes the above four mentioned conditions also may be misdiagnosed as placenta accreta, and maybe going for cesarean, going for hysterectomy without separating and leaving the uterus. So it is very important, this classification, to start with your ultrasound skills to see what is placenta accreta and placenta previa, scar defect with placenta previa, low-lying placenta, and only the scar defect, but there is no placenta accreta. So it is very important. So that is the very important classification that we have to make, that high probability of placenta previa accreta, because there's high chance of bladder injury and massive transfusion, and may need emergency hysterectomy. So this is the latest ultrasound classification. Then going for the FIGO classification, this will be very helpful in our management. So why it is needed? Because if you identify the woman risk from at-risk population, accurate diagnosis. If you don't diagnose it properly, minimize false negative, undiagnosed invasion, so that will avoid major morbidity and mortality from hemorrhage and urinary tract infection, injury, and unplanned loss of fertility will be minimized. If you minimize the false positives, unnecessary interventions, avoid major morbidity and mortality from intervention, and hysterectomy and other unnecessary loss of fertility is minimized. So it is very important when you decide on what to do with your ultrasound diagnosis. So as the previous speakers mentioned, like the others, antenatal optimization with hemoglobin up to 11 grams, and informed written consent for hysterectomy in case, explanation of the procedure and risk of benefits, discussion of anesthesia options. Nowadays, I do miss most of these with the combined epidural and spinal. So it is very easy to perform the surgery with that kind of anesthesia, but some others prefer general anesthesia. And the consent for not only for the hysterectomy, for massive blood transfusion, at ICU admission and sterilization also important. And clarification of patients concerned about the fertility and documentation and patient signature, all these are important in your planning. So multidisciplinary team involvement. It's very important to have a experienced anesthesiologist. Otherwise, we will have to order them what to do with the massive hemorrhage. And neonatologist if it is a preterm delivery or in case of other issues, and transfusion physician. Those three are the main important. In my case, because I don't get the urologist or GU surgeons in case because it is mostly optimization of the hemoglobin in case if it is needed, steroids and magnesium sulfate when it is a preterm delivery. We cross-match 6 units of blood, 6 units of platelets, and cryoprecipitate 10 units. So this is the number that we preserve when it is a diagnosed case of placenta accreta spectrum, then for placenta previa and solid for 6 hours and fluids for 2 hours. And we have this checklist in my hospital about the diagnosis as well as the preparation. So most of the time this is prepared because this is for the plan A. If once we prepare this kind of everything with the checklist, if there's an emergency situation, it's very easy to carry out emergency surgery when it is plan B or something. So there's another checklist made by the American College, but this is more for hysterectomy. So in my case, it's mainly the indwelling catheter is kept, post-operative monitoring of fluids and balance vital. Combined spinal, I have the videos, but I don't think that there's time with the video presentation. And then these are the minimal steps: entry with the suprapubic transverse incision with minimal blood loss, and then identify the lower segment, and delivering just above the scar level with the placenta intact, and then clamping the uterine wall with the placenta intact, and then gradual removal of the placenta and suturing from one end to other end. So it is very important to not to remove the placenta soon after the delivery of the baby. Clamp it to the uterine wall, give you oxytocin, tranexamic acid, and massaging, and then make sure the upper part is hard, the bleeding is minimized. Once you do this procedure, it is very minimal bleeding with the separation of the placenta end to end without completely separating at once. And sometimes there may be difficulties in separation. In those cases, we leave that small pieces of placenta and stitch it to the uterine wall. That won't do any important big bleeding. Suprapubic transition, lower segment, cauterizing superficial vessels and surface, and then early entry of the lower segment with the low transition, transverse incision, delivery of the fetus, and immediately clamping the cord after delivery of the baby. And uterine incision is made avoiding the bladder margin as well as the large neovascularization. So keep some margins below the area. And exteriorization of the uterus and clamping uterine incision edges with the placenta accreta, placenta mass with the green hermitage. And sometimes both uterine arteries are clamped with long artery forceps whenever necessary. And then upon the delivery of the fetus, the uterine incision edges immediately clamp along with placental mass with multiple green hermitages. And as I said, it's important to stop bleeding there, and then only you start your surgery, leaving compression of the uterine walls on either side by gripping the uterus from posterior aspect of the uterus, gradual removal of the placenta from posterior aspect with placement of local hemostatic sutures if there is bleeding from the surface. So that's separation gradually. And then suturing start from one end to other with gradual separation of the placenta. Sometimes it bleeds, so when it is bleeding, the hand on the posterior aspect can control the bleeding on the posterior side. And in case of massive hemorrhage, rather than going for this complete surgery, internal manual aortic compression is like closing the gate valve in a leaking tap, so it will keep the area very much dry, as well as in that case we may have to do rapid infusion of blood and blood products. So for that we have the rapid infusion ready, which is sending 1 liter of blood per minute, and clamping the cervix if there is bleeding from below. Have to separate the placenta. They are clamping the cervix to the the descending cervical vessels from the vaginal root may stop the bleeding from below. So it is very important not to separate the placenta in case of there's massive hemorrhage. And this stitches can be applied from the posterior aspect of the cervix of the uterus with a long needle that we are using to compress the posterior aspect of the uterus if there is bleeding from the lower segment posterior. And that is important to keep the internal os open all the time, otherwise blood will collect inside. So 2-layer close of the rectus sheath and skin is done later on. It's a teamwork, so you need good assistance. So you can see 2 of my assistants and a lot of anesthesia colleagues are around, and 2 nurses are helping to give this suture materials and the instrument very quickly. Otherwise, if there's delay, every minute, every second, it bleeds and it deteriorates the woman. So this has to be done within a short period, otherwise we'll have more loss. And post-operative care, depending on the situation, if she has lost a lot, we may need ICU admission, if not HDO ward, monitoring vital signs, pain relief, fluid management, removal of vaginal inserted cervical clamps, if there are clamps kept for hemostasis later on, in early enteral feeding, otherwise there's a chance for them to develop paralytic ileus, and catheter removal, early mobilization. Sometimes we are using the TD stockings and other measures to minimize the DVT. So this kind of approach we do in my Casa Street Hospital without single maternal death and saving uterus and lives. And most of the time they go home quicker than when you do a hysterectomy. Sometimes there's a chance for the bladder damage. Sometimes there's a risk of infection and massive hemorrhage and transfusion. So thank you very much for listening my talk. Thank you.
Thank you, Dr. Ratnasiri sir, for explaining us the important topic. With the help of it, we can reduce maternal mortality and morbidity. And he has explained many new things, and he has explained recent FIGO guidelines, how to diagnose and how to manage placenta accreta in Lisud language. Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, Dr. Thank you, Dr. Sneha Boyar and Dr. Supriya Jaiswal for inviting me. Thank you.
Thank you, sir. Thank you for the wonderful talk, Dr. Ratnasiri sir, and for chairing the session, Dr. Rajendra Singh Pardesi sir. So thank you. And now we move forward for the next talk by Dr. Poonam Shivkumar. And to introduce her, may I request Dr. Kiran Koti sir, kindly introduce the speaker. May I have the CV?
Yeah, thank you. At the outset, a very fantastic webinar that you are conducting, Dr. Sneha. Really, I must admire this. This is one of the largest attended webinar which I have seen over the past 6 months or so. So fantastic course. Congratulations to you. Thank you, Dr. Supriya, for inviting me on the dais. And it's really a privilege for me to introduce a very good friend of mine for the past, say, 20-25 years or so, ardent Amoxian, a very hardcore teacher, Dr. Poonam Verma Shivkumar. So Dr. Poonam is an alumni of the prestigious Sevagram, that is the MGIMS Medical College. She has done advanced training in sexual health and reproductive health from Uppsala University, Sweden. She is also alumni of JIPMER, for the clinical skill training program in the EMOC for CMC Vellore. She is a core member of the PPH working group, that is FIGO. She is the ex-president of the Sevagram Society, Varli Savangi Society. She is also the principal investigator for research studies on partography by Jeevdaya Foundation, USA, stillbirth and pre-viable birth defect project by WHO, CRO, and low-cost salivary progesterone for predicting preterm levels by All Children Thriving Grand Challenges and Bill and Melinda Gates Foundation. She is a TAG member of the Indian Clinical Epidemiology Network, that is INCLIN, which is a very commendable thing and a really appreciable thing. She is also a recipient of the Doctor's Award for Management of Anemia. You know, sickle cell anemia is a very prevalent thing in the tribal belts of Maharashtra, and that is why probably AMOX has also insisted on doing HB electrophoresis to diagnose hemoglobinopathies and sickle cell anemias in all patients. So a commendable work done by Dr. Poonam. She has chaired and given several orations, guest lectures, and paper presentations at national and international conferences like IMA, FOXY, AMOX, NOGS. To her credit, she has over 80 articles, 8 chapters in various national publications. And to congratulate you, Dr. Poonam, she is also mentored by Dr. Shakuntala Chabra, a very revered teacher of practically many Amoxians. And we are really fortunate to have you on the dais. And currently, she is also the head of department of the Sevagram OBGY department. And now I think, Dr. Poonam, you are also the superintendent of the Sevagram Medical College. So I think that's your latest feather in your cap. So thank you, and over to you, Dr. Poonam, for your talk.
Thank you so much, Kiran. Thank you very much. I'll just begin with my talk. Can I share my screen?
Yes, yes, madam.
Yes.
Is it there?
Yes,
Yeah.
it is same.
And is it moving?
No,
Yes,
madam.
they try moving once. Yes, yes.
Oh.
So welcome, madam.
Thank you. First of all, let me thank Sneha. She always invites me for some sessions which are really very close to my heart. So with that, I'll just, is it on this one, slide mode?
No, ma'am. Just you have to make it in slide mode. Full screen. You have to make it full screen.
Yeah, full screen.
Niche on the right.
Yeah.
Full screen.
Come to that
You can make
right-hand
a
side. madam.
slideshow, no? You can
Yeah,
put,
I'm just seeing that.
click on the icon right at the right corner, right at the bottom. Yes, close to that.
Yeah.
No, nahi,
Next
uske baaju
next
ka.
to that.
Right side, right side.
Yeah.
Right side,
Right.
right. Right side. Just move your cursor.
On the lateral side.
Or right.
No, not this,
no,
not
madam.
this.
Next to that, next to
This
that,
one?
next
Baaju
to
wala.
that.
Yeah. Is
Yes,
this
done.
good? Yeah.
Yes, ma'am.
So a very good evening to all of you. What I am going to talk to you today is sickle cell crisis in pregnancy. And I bring greetings from Mahatma Gandhi Institute of Medical Sciences, an institute where I am very proud to be. Presently, I am not head of the department. I am director professor, and I am looking after the medical superintendent office here. Coming on to sickle cell disease and sickle cell crisis, let me just begin with some very important fact which you need to know. So sickle hemoglobin is a genetic disease which is due to point mutation in beta globin chain. This point mutation replaces A with T at codon 6 of beta hemoglobin chain. This causes the switch from glutamic acid to valine amino acid. And this valine type of hemoglobin causes red blood cells to sickle when they are exposed to any kind of low oxygen threshold. Now, this abnormal hemoglobin, HbS, causes the red blood cells to assume an abnormal, rigid sickle shape. Sickle cell decreases the cell flexibility, results in clumping, and then it causes a lot of complications. Now, if you look into this hemoglobin, you will realize that it has a heme component, and these are the beta and alpha chains. And there is a mutation which you can see. There is a normal protein. with glutamic acid and mutant protein with malic acid. And this is responsible for the shape which is called sickle cell. Now, look into this, that when you talk about a normal red cell, they are flexible, they can pass through the blood vessels, but whenever it comes on to sickle, they all start clumping together and then they end up in crisis. Whenever we talk about the inheritance, we are all very clear that it is autosomal codominant kind of inheritance. We have two types. One is sickle cell trait, where one parent, if you see, gives HbA, the other parent gives HbS, and we end up in AS. When you talk about sickle cell anemia, both the parents, they give HbS and the pattern which comes as SS type. And this is where we are concerned about disease and crisis. Sickle cell trait, there are a lot of research work going on. Very rarely you will see them going into any kind of crisis, or in a very abnormal situation only, they will have some kind of morbidities in the women. Now, these are some very special diseases which happen with sickle cell. It could be sickle cell C disease. It could be sickle cell with beta thalassemia. It could be sickle cell with any other variety of gene like hemoglobin D, E, C, but all of them are put under sickle cell disease. Coming on to epidemiology, the highest prevalence of sickling in the world is in sub-Saharan Africa, followed by Arabian countries and Indian subcontinents. USA and Latin America has very little, especially in the blacks, where they have more of SC gene as compared to SS. In India, we see that the tribal community, as very rightly said by Dr. Kiran, and ethnic group in central India, including Vidarbha region in Maharashtra. We look here, lot of people who belong to Kunbi community, they come with sickle cell disease. Also, it is seen that in Nilgiri and certain regions of Kerala, there is very high prevalence of sickle cell disease. Coming on to pathophysiology of sickle cell crisis, which I am talking about, and I will limit myself to that. There are two major events which happen. One is vascular occlusion because of this sickle cell clumping, and second is hemolysis of these cells because they have very short lifespan. And this happens due to HbS polymerization, sickle cell deformity, sickle cell blood viscosity, sickle cell adherence, endothelial cell activation, hemostatic activation, WBC and platelet activation, enhanced local and regional inflammatory response, and of course, ischemia. The crux of all this is that there is sickle cell which is adherent to the endometrial cell, and these are the consequences. Now, coming on to sickle cell crisis, the most acute event and the first crisis which all of us know is vaso-occlusive crisis. The women presents with dactylitis. She will say that she has numbness in the fingers. And believe me, this is a very bad sign. We should never ignore it. Joint pains, of course, knee joints, elbow joints, every joint is painful. She will come with abdominal pain because of the sequestration crisis and vaso-occlusive crisis, which is happening in the liver and spleen. Severe kind of body aches. There is one very important entity, which is acute chest syndrome, and in a minute, I'm going to talk about it. There are several central nervous system events where stroke is one of the commonest one. And there are various type of infections because with the anemia, hemoglobin going down, the immunity being reduced, there are several infections which happen. Beyond this vaso-occlusive crisis, there are three other variety of crises in which the first one is hemolytic crisis. And you will see that bilirubin significantly starts increasing. She becomes yellow and her hemoglobin goes down. In this hemolytic crisis, the megaloblastic crisis is the worst one, where she is severely folate depleted. Then comes on to the sequestration crisis, which happens mainly in the spleen. And what happens is, you all know that there is autosplenectomy, which is another reason for having several infections. And then, of course, the last but not the least is aplastic crisis. So if we look into the fate of this sickle cell crisis, so these red cells, because of low oxygen tension, they are deoxygenated, sickling occurs. Cell passes through the circulation, but then once it passes, there is good oxygen tension, de-sickling occurs, and these are various cycles which keep on happening. So she has a little bit of pain, but it gets relieved. And therefore, there are changes which do not happen as bad as the acute crisis. But then if it is irreversible, then in that case, there is change in the cell permeability, there is fragility, and there is intravascular hemolysis. Even with the hemolysis, you will see the initial stage, women does not really report to you until she becomes absolutely yellow. Then when sickle cell RBCs clump, macrophages come to phagocytose. There is extravascular hemolysis in the spleen, and this leads to chronic hemolytic anemia. And whenever there is chronic hemolytic anemia, some kind of inflammatory markers come in which activate the platelets. And then what happens is that there is alteration in the functions of platelet as well as white cells. Coming on to also, when the sickle cells are clumping, they adhere to the endothelium. And then what happens is that there is vascular stasis because viscosity is increased, vascular occlusion, infarctions, tissue damages. Spleen infarcts are very, very important because whenever there is hyposplenism, the lady becomes very prone to pneumococcus and S. typhi infections. And these septic pneumonitis and septicemia leads to death. And that is why we are really concerned about this sickle cell disease. Now, if we look into pregnancy with sickle cell disease, believe me, these are these are very recent figures which are coming from different research literature, that these are the things which women suffer with. There are antepartum hemorrhage, abortions, eclampsia, severe anemia, and severe infections. There are some unspecified reasons also, which when you divide and look into, they again go into anemia. 6% remain unspecified, and then of eclampsia when you really go into depth of it. If you look into the fetal problems, then of course, because of repeated crisis, there's IUGR, birth weight is very, very low. They are also small for gestational age. They are premature because many times because of repeated inflammatory markers, prostaglandins are released and the women delivers much earlier, and there's very high perinatal mortality. There is definitely increased maternal morbidity and mortality. Previously, sickle cell disease was a disease where we were not expecting them to come to the age of reproductive age group where they can deliver or the issues they can have. But later, you know, with the invent of hydroxyurea, the vaccines and so on and so forth, women are coming up to this age. But the average age, which has been mentioned in the books, that they may continue is nearly 52.6 years. Coming on to what clinical features the women with sickle cell disease or sickle cell crisis women will present to you. So they are broadly divided into acute events, which you say crisis, and chronic complication. So whenever there is acute crisis, this necrosis, the avascular necrosis happens where phalanges, metacarpals, metatarsal are affected. There's huge, big respiratory symptoms which appear, and the women suddenly becomes breathless. She's gasping. And when you do all tests, you find that there are severe kind of pulmonary infiltrates in the X-ray chest. Suddenly, she will have symptoms of one side hemiparesis and hemiplegia or aphasia and seizures. So obviously, these are cerebral events. She may present you with severe anemia because of hemolysis which has happened. And of course, all these infections, streptococcus pneumonia, E. coli, staphylococci, which is responsible for osteomyelitis and, of course, salmonella infection. And then, of course, when you talk in terms of chronic, of course, anemia, arthritis, hyperbilirubinemia, depressed immunity due to autosplenectomy. Aplastic crisis is worse, and it is said that it is mainly because of viral infection, where human parvovirus have been mentioned to be the main reason for this kind of crisis. There is extensive marrow crisis in this. Very short red cell lifespan is there in these sickle cells. And this kind of crisis finally end up in all three crises. That means RBC, WBC, and of course, platelets also. Splenic sequestration, I have already told you, there is sudden trapping of blood in the spleen. There is massive sequestration, and these sickle cells, finally, the whole spleen gets sequestrated completely, and then autosplenectomy happens. There's hemolytic crisis, as I've already told you, that suddenly you will see that the hemoglobin is falling down, the reticulocytes are elevating, and bilirubin is rising. And this is mainly seen with G6PD deficiency. Now, coming on to chronic, even these are the things which can happen. There's huge big problem with the growth and development of the baby. Avascular necrosis of femoral head can happen in the women. Pulmonary symptom, hepatobiliary symptom, GI symptom, kidney, eyes, all can be affected along with the leg ulcers. Now, what are the factors which are responsible for crisis in pregnancy? So please remember dehydration, any kind of acidosis, infection, hemorrhage, and of course, pregnancy is a hypercoagulable state. And if all these things happen, there is further hypercoagulability. And these are the reasons where the crisis happens. What are the lab tests you do? Because now this woman is already diagnosed to have sickle cell disease. That is why she is going into crisis. So you've already done hemoglobin electrophoresis, and you have seen that the woman is SS-type. But during the crisis, in acute phase, you need to have a CBC and peripheral smear. Acidosis profile by doing blood gas analysis is mandatory. Renal functions have to be tested because kidneys are also affected. Hepatic profile, full liver function test because liver is affected. The eyes are affected, so fundoscopy is mandatory. And ultrasound scan is mandatory to find out regarding the spleen, the GI tract, and of course, the liver. Urine culture sensitivity is mandatory here because infections which mainly start from the urine. And then finally, if nothing works in, you have to go for bone marrow testing. I'm not going to go in details that these are the things which you see generally. Below this, if it starts going, you consider it as abnormal CBC. So sickle cell, target cell, polychromatophilia, you will see in WBC, the count will suddenly start increasing. The platelet count surprisingly increases, the reticulocyte increases, the ESR is markedly reduced. Bone marrow, you will see erythroid hyperplasia, which is very peculiar, and normoblastic erythropoiesis will be there. There will be megakaryotic poiesis and granulopoiesis. Iron stores in sickling are very, very high, and that is the reason we have to be extremely careful for giving iron therapy. Now, how do you manage this sickle cell crisis in pregnancy? So before we really go into the acute management, these are two things you need to know. Vaccines are very, very important. So any women who is sickle cell disease, you have to give these polyvalent pneumococcal vaccine, Haemophilus influenza type B, and meningococcal vaccine. These are recommended by all guidelines, I would say. And nowadays, people are also saying that given COVID vaccine, influenza vaccine, and so on and so forth should also be given. Hydroxyurea is one drug which is used for sickle cell disease, and it has completely changed the scenario. It has clearly demonstrated that it improves the survival and reduces the incidence of main causes of death, acute chest syndrome, vaso-occlusive pain, and complication. Problem is that this is not recommended in pregnancy. But when it comes to saving life of the women in acute crisis, hydroxyurea has been recommended by several guidelines. Acute management is you do a rapid clinical assessment, but do not let this women dehydrate. So you have to go give fluid therapy. And we expect that in a day, nearly 3 to 4 liters should go. But at the same time, you have to see that she should be not such severely anemic that you give this much amount of fluid and she goes into pulmonary edema. So you have to calculate input and output, and accordingly, you have to give fluid therapy. Strong analgesics are to be given because the pain is such severe that she's barely able to bear, and that causes more of tachycardia and decompensation. So in that case, morphine has been recommended, but non-opioid analgesia, like nowadays what we are giving is paracetamol drips, we are giving non-steroidal anti-inflammatory drugs. If 12 to 28 weeks of gestation is there. Before 12 weeks, generally crisis does not happen, happens after that. So before 12 weeks, we simply give paracetamol if somebody comes with pain. Some kind of laxative, antipruritic and antiemetic drugs are given depending on the symptom. And what is most important is oxygen saturation. We can give 5 to 6 liters of oxygen, but it all depends what is her oxygenation and how are you maintaining it. Remember that one single dose of analgesic or giving it in few hours does not really help. There are a number of rescue doses of parenteral opiates which you have to give. The crux of this whole thing, when she is severely anemic, is blood transfusion, which actually manages the sickle cell crisis. So blood transfusion with only packed cells, because this woman is severely anemic, again, she will go into pulmonary edema. And then once her pain is controlled, you may discharge her, but you have to tell her that she has to repeatedly come to you for antenatal checkup and give her appointments so that she knows that she's not like a normal woman. She has to repeatedly come to you because crisis can happen at any moment. When we talk about blood transfusion, there are certain places where we have to be careful also, that in stroke, in cardiac failures, etc., we have to see what amount of blood is to be given. So that calculation has to be there. The recent studies are on and they are talking too much about stem cell transplant. And we all know that sickle cell disease women, when the baby delivers, we always take the cord blood and preserve it so that we can have stem cells. And these stem cells have been proved that in the later ages, if the baby has some kind of sickling, the baby can be given. However, nowadays, any husband-wife, if they are ACE kind of sickling also, to prevent any SS baby, prenatal testing is done using chorionic villus sampling. And we know right from the beginning how the baby is, so that, you know, the parents do not suffer with that kind of pain that they deliver SS baby and end up with some kind of life-threatening complication.
Sorry to interrupt, madam. Time you'll have to.
Yeah, I'm just finishing. So stem cell gene additional therapy, gene editing therapy, these are two new things which have come up. And we must, all of us must look into it because these are something very new which are coming up. And last but not the least, the drugs which are coming up, and there's a lot of research going on. So these three drugs, voxeloton, L-glutamine, and crizanlizumab. These are the three drugs which are coming up with lot of research. We are expecting that there will be some kind of change in the crisis when it comes in. So intrapartum care, there is nothing much. We can go for even vaginal delivery or elective birth. So it's not a contraindication that you should not have vaginal birth because you are sickle cell disease. And this is something, last slide, that postpartum care is very, very mandatory. Adequate hydration. Low molecular weight heparin has been recommended by Green Top guideline that it should be given for 7 days, so that, any kind of clumping or anything which is there, it can be taken care of. And then, of course, they should come in for checkup as early as possible up till 6 weeks. So thank you very much for your patient hearing.
Fantastic talk, Dr. Poonam. I only have one query. So to prevent any vaso-occlusive events, do we advocate regular low-dose aspirin for all these patients once they get pregnant?
So, sir, if you ask in practice, we are all doing it. We do give some kind of heparin. And also, you will be surprised that people are giving Eno sachet. And this is a practice in even the medical colleges to prevent acidosis.
Yes.
So they give those Eno sachet, which is alkaline, and that also has worked very well. However, there have been no literature and no big studies. However, things have worked very well. So these two things can be given for prophylaxis.
I think the Sodament tablets, it's
They
still
are also available.
being used.
And Eno sachets are also available. So in routine practice, if you see, everybody is giving it.
Yeah, even
However, literature is not there stating that one can go ahead.
Yeah, so Sodament tablets and low-dose aspirin, and some of the hematologists are even giving the fundoparinax injection or low molecular weight heparin. It's giving
There are very debatable literature about low-dose aspirin because it has led to a lot of abruptions in placenta. So yet it is debatable, but routine practice, people are still trying.
Thank you. Thank you so much for that lucid talk. Excellent, as always. I also acknowledge the presence of Dr. Pardeshi, Dr. Vidya Thobi, Dr. Aruna Suman, Dr. Alka Pandeji, and Dr. Zungare Madam.
Thank you, sir. And
thank you, Dr. Kiran. Thank you for chairing the wonderful session. Thank you.
So I would request now for the next talk, Dr. Aruna Suman, and to introduce her, may I request Dr. Pardesi, sir, to kindly introduce Dr. Aruna Suman, madam. Dr. Pardesi, sir.
Yes. I would like to invite Dr. Aruna Suman, ma'am, for this next talk. So, Dr. Aruna Suman, so I think she doesn't need any introduction. She was our joint secretary of FOXI, the National Quality Assurance, then Accessor TOT Telangana. There are many orations and all accolades in her credit. So I would like to request Dr. Aruna Suman to give her next talk. Over to Dr. Aruna Suman.
Respected Chairperson, thank you for the introduction. My sincere heartfelt thanks to Dr. Sneha Buyar, Dr. Supriya Jaiswal, and Monica. Thank you for this good opportunity. Now I'm sharing my presentation. Please let me share the presentation.
Yes.
You are posted, ma'am. You can share the screen.
Okay. No, still I'm not able to share the presentation. It says one participant can share at a time.
Now you can try.
Okay.
You can make it full screen, madam.
Yes. Dr. Sneha Buyar, thank you for this opportunity and thank you for selecting this topic for me. And it's a very good topic, very important topic. Non-hemorrhagic shock in obstetrics. What did we learn by this? Shock during pregnancy is one of the most difficult problems faced by obstetricians and necessitates initiation of management even before full identification of its form of better survival. There is an inadequate tissue perfusion causing cellular hypoxia and organ damage. Don't do the timely intervention. Definitely, they're going to land up in a problem because she's going to have organ failure. So this is what is happening. This is the physiology that is happening. It's tissue cellular respiration can multi-organ failure and death. We all know about the clinical picture of shock, and there can be sometimes it can be guiding, especially in septic shock. The temperature will be subnormal. Low temperatures are seen instead of high temperatures. So high degree of suspicion is very important. And the mental status, the confusion is also important in the shock. So I'm going to go into the pathophysiology of this shock and what are the types of shock we see. This can be hypovolemic shock, cardiogenic shock, anaphylactic shock, and neurogenic shock. And what are the other types of shock? Actually, the circulatory system. So it can be distributed, where we can see the septic shock or sometimes a non-specific like Raleigh, etc. Cardiogenic shock. This is seen in cardiomyopathy patients or arrhythmogenic patients where there is irregularity. Hypovolemic shock can be two types, hemorrhagic and non-hemorrhagic. And obstructive shock is pulmonary and mechanical. So let's see what exactly are the other types of shock. The stages of shock. So we have to intervene early. So the early identification shock and early management during the compensatory mechanism is important, or else we're going to have the irreversible shock. So it's a stepwise approach because of the type of the shock. When the man is in shock, you're not going to think about the cause and we're not going to waste time. Immediately we have to act. Code blue should be activated. Identify the stage of shock, multidisciplinary approach, ABC should be done, including the fetal monitoring. Identify the cause and type of the shock. Laboratory evaluation, IV fluids, blood pressure, and vasopressors can be used to shock. So we should remember the shock index, which is important in the emergency department HDU or OICU. We have to, for the prognostication of the patient. If it is more than 0.9, that means the patient is critically ill. We have to remember there is modified shock index, which is heart rate by mean arterial pressure. If it is 1 or more than 1, that means the patient is critical. Coming to these are the real cases I'm going to present today. The case history. Gravida-4 para-3 live 38 weeks, delivered normally. The placenta delivery caused explosion of uterus. That could be because of mismanaged third stage of labor. There was severe pain. Shock was out of proportion. The manual reposition was done after resuscitation. Uterotonics were given, and the patient was monitored and discharged on 5th day. So what is this? This is the type of shock. What of shock is seen in inversion of uterus? It is neurogenic shock. Tension on the nerves due to stretching of the inferior-pelvic ligament. Pressure on the ovaries as they are dragged into the fundus to the cervical ring. Peritoneal irritation, hemorrhage, especially after detachment of the placenta are seen. So sometimes even there can be hemorrhagic shock whenever there is, if it is associated with excessive bleeding. So what are other types of neurogenic shock? For example, the neurogenic type of is seen in ectopic pregnancy, concealed accidental hemorrhage, sepsis, or a breach extract before full dilatation, cervical dilatation, rough internal version, etc. So, how do we manage this neurogenic shock? The management of inversion of uterus. Before shock, earth manual reposition, even without anesthesia, can be done. Replace the part first, which is inverted last. The support with the other hand placed on the abdomen till the uterus is well retracted. We have to give the uterotonics, and only after the uterus is well retracted or contracted, we have to remove the placenta. If suppose the woman is in shock. Call for help. We have to treat the shock. Only after hemodynamic stability we have to remove the placenta, or manual removal of the manual reposition of uterus is done. What are the other type of management of inversion of the, suppose we are not able to do the reposition? One is hydrostatic reduction. This is O'Sullivan's method. And during laparotomy, we can do Huntington's method, which is gentle traction with Ellis forceps. Halton's method, which is incision on the posterior aspect of the cervical constriction ring. And Rodison's incision is given on the anterior ring. And we can use the silicone during laparotomy to actually reposit the uterus. And laparoscopic reposition can be done. If it has been very difficult, the last resort is hysterectomy. So we have to remember, we can definitely take care of version of uterus. But recently, there's a re-inversion and loss to women. So we have to pack the vagina and observe it. Monitoring is very important. Prime with PROM, given antibiotics, cesarean section was done as there was no progress. And third POD, she developed loose motions and vomitings, 14 episodes. She went into shock and she was resuscitated with fluids and antibiotics. So it is a cause of this is because of hypovolemic shock. Maybe the input-output chart was not maintained properly, and the antibiotics, the proper antibiotics were not given. So we have to take care of the hypovolemic shock immediately, or else we are going to lose the women. So hypovolemic shocks, hemorrhagic and non-hemorrhagic, because of the fluid loss, also this can happen. So as a level of consciousness in association, Glasgow coma scale, and act immediately, resuscitation should be done. Coming to the third, it was the fourth Pravda para 3, lively 38 weeks, 3 days, came with came to our hospital complaining of breathlessness with cough. There was no history of previous respiratory infection or any heart disease. She diagnosed to have cardiac failure. The hemoglobin was 11 grams. The person, that means she is not even anemic. She was resuscitated and she was diagnosed to be a cardiomyopathy. And this is a cardiogenic shock. So these are the various causes of cardiogenic shock during pregnancy. One of the reasons, cardiomyopathy, pulmonary embolism, valvular regurgitation, acute myocarditis also is one of the causes. How can we diagnose cardiomyopathy? All four following can be there, like heart failure within last month of pregnancy, 5 months postpartum. There can be absence of prior heart disease, no determinable causes, strict echocardiography. There is left ventricular dysfunction, ejection fraction is less than 45%. So this is the protocol to identify cardiomyopathy and the diagnostic testing. These are used for diagnosis, chest X-ray, ECG, and the most important diagnostic tool is echocardiography. So this is how we are going to treat the woman. It's the acute treatment. If the woman is in acute stage, we are going to treat her with oxygen, diuretics, vasodilators, antiarrhythmics, inotropic drugs, mechanical ventilatory support, anticoagulation, and pentoxifylline, intravenous immunoglobulin, and bromocriptine. If it is a chronic disease, there are various methods to actually treat the woman and to follow the woman, and she has to undergo 2D echo once in 6 months. For 3 years, later once in 1 year, once in 1 year. Subsequent pregnancy, if the ejection fraction is more than 45, she can conceive, and we'll have to monitor the woman. If the ejection fraction is less than 45, again there is going to be persistent LV function. So 50% show further deterioration in LV dysfunction. So we'll have to wait and counsel the woman. Coming to extra cardiac shock, massive pulmonary embolism, amniotic fluid embolism, anaphylaxis, etc. And coming, one more woman was there who was 8 to 9 weeks pregnant, unwanted pregnancy, has taken over-the-counter medicine. MTP kit was taken, and RMP conducted the abortion. She came to us, fever, severe pain, toxic look. She was in shock. and we have diagnosed shock and sepsis. Dental care was given. She developed renal failure and multi-organ failure and expand fourth day. We all know the signs of sepsis. So we'll have to remember her temperature can be lower on, but high degree of suction when she's having tachycardia, heart rate is 100, respiratory rate more than before. She's in a confusion, clamminess, a rash. We have to remember this. So think of sepsis in retail products of corruption after cesarean delivery, which diabetic and there may other cause. Maternal sepsis, according to WHO, is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. This definition has been endorsed by FIGO and is generally followed. WHO also emphasized that the criteria of systematic inflammatory response syndrome, that is SIRS, are not appropriate for diagnosing maternal sepsis and should not be used. There are many causes of sepsis, septic abortion, chorioamnion, post-cesarean. We know all those causes. And pharmacological agents we are going to use are inotropics, corticosteroids, vasopressin, and thorough monitoring. So with Mio's chart is important. This is the nutritional support that should be given. And definitely we have to basic life support or advanced life support if necessary should be definitely done, and we should be ready. Our facility should be ready everything to resuscitate the women with sepsis. These are the causative organisms, the commonest being E. coli, and the effects of sepsis can be in all the organs, especially central nervous system, cardiovascular, pulmonary, and all the systems. So quick transfer to the tertiary medical institution because of multidisciplinary approach and blood bank availability is important. Suppose there is a foci of sepsis, septic abortion, or uterus itself is septic, we have to remove. We have to do a hysterectomy. The foci of sepsis should be definitely done, or else the prognosis will be very bad. The sepsis kills. So recognize, resuscitate, and refer. This is how we evaluate, and we have to take action, and proper sepsis treatment should be done. These are the vasoactive agent managed according to the evidence. I'm not going to go into the detail. There is an optimization of sepsis bundle. So 2005 to 13, in 18 and 19, there is one hour bundle. So we'll have to do everything in 1 hour for the better survival of the woman. What are the 5 elements of 1 hour bundle? Measure lactate level, measure if initial lactate is more than 2 millimoles, obtain culture prior to administration of antibiotics, administer broad spectrum antibiotics, begin rapid administration of 30 ml per kg crystallized for hypotension or lactate is more than 4 millimoles, apply vasopressor if the patient is hypotensive during or after resuscitation to maintain the MAP above 65 millimeters Hg. The time 0 or the time of presentation is important to immediately start the treatment. The lactate in sepsis has got a role. This gives the prognostication of the woman. So prevention is better than cure. So standard precautions should be always taking. The aseptic precautions are important. Coming to the extra cardiac, I'm not going to go into the detail as we further have the talks. Dr. Jam Kannan Madam, Dr. Vidya Tubi Madam are going to speak on this. Depending on the circulatory system, these are the distributive or the obstructive causes of the shock, amniotic embolism, pulmonary embolism, and anaphylactic shock. Till now, whatever pulmonary embolisms or amniotic fluid embolism cases we have seen couldn't resuscitate those women. And yes, anaphylactic shock, we can definitely save the woman. We all should know the basic life support, especially few things that we should remember. Yes, 1 minute. So we have to do 30:2 CPR, and we have to do it just above the sternum. For perimortem cesarean section has got a role. If there is a cardiac arrest and if we are able to resuscitate the woman within 5 minutes, we have to do a postpartum cesarean section. Cesarean section can be done. Advanced life support should be immediately called upon. And in resuscitation, always the uterus should be placed with 2 hands or 1 hand for the resuscitation. We all should know the defibrillation, and definitely there should be a code blue, rapid response team, facility readiness, crash cards at different places, not only at OIU and HDUs, skill enhancement drills every month. We should at least learn the basic life support skills and train everyone in this. Thank you so much.
Thank you, Dr. Aruna Suman, for this important topic on non-hemorrhagic shock in obstetrics. As it's many causes for this and many situations, but that's why really important about this. Hence, there are medico-legal situations also, and we have to explain to patients also. That's why this topic is really important. And Dr. Aruna Suman has explained many situations. There are many situations, but like inversion of uterus, hypovolemic shock, cardiogenic shock, septic shock, amniotic fluid embolism, pulmonary embolism, anaphylactic shock. She has explained really nicely. Thank you. Thank you so much, Dr. Aruna Suman.
Thank you so much, sir. Thank you. Thank you, sir.
Thank you, sir. I really thank all the speakers and the chairpersons for this first session. Now, quickly we move over to the second session because we are running short of time. So,
call the chairpersons.
Yeah. Can you see, madam?
Yes, we can see. You can invite Indrani.
Yeah, so to chair the session, we have Dr. Indrani Roy. She is MD FICOG, Senior Consultant and HOD Obstetrics and Gynecology, Nazrat Hospital, Shillong. And she's also the President SOGS of 2017-19, Organizing Chairperson East Zone, Yuba Foxy in 2019. One sec. The second chairperson is none other than Dr. Niharika Malhotra. She is very young, vibrant Foxian, very active member. She was the chairperson of Foxy Young Talent Promotion Committee recently, and she has many awards to her credit and accolades to her credit. So welcome, Dr. Niharika. The third chairperson is Dr. Pushpa. Madam is HOD OBGY at Amravati, and she has got affiliations to many organizations, and she is the recipient of many prestigious awards. So welcome, madam. And then Dr. Charulata Bapai, she is the chairperson of and she is actually a consultant obstetrician and endoscopic surgeon, and then she is also the chairperson of Study of Female Breast Committee of Foxy. Welcome, Dr. Charu. And then fifth chairperson is Dr. Saijas. He is also the chairperson of Midlight Committee of Foxy. And welcome all the chairpersons. And now over to the speakers. So I request Dr. Niharika Malhotra to kindly introduce Dr. Vidya Thobi, madam, the first speaker.
Thank you so much, madam, and thank you, Sneha ma'am, for having me here. It gives me great pleasure to actually introduce Vidya madam. Vidya ma'am is professor and head of department of OBGYN at Vijaypur. She's also been the Kasoga president-elect chairperson. She's been the past chair of Food and Drug Medical Legal Surgical Equipment Committee of Foxy, and also very active ICOG Governing Council member. Welcome, Vidya ma'am, and over to you.
Yeah, thank you, Niharika. I would like to share my screen. And I think this is an old CV which is shared. At present, I am a president Kasoga itself. So thank you very much, Niharika. And today they have given me a very important topic. And I must thank the ICOG for giving me this opportunity, as well as Sneha. She is a very dynamic leader as well as a great organizer. I thank Supriya as well. So I hope my screen is visible.
Yes, madam. You need to make it full screen.
Yeah, full screen. Yeah?
Yes, ma'am. Perfect.
Yes. So today the topic which is given to me is a very important topic and which is the most neglected topic as well. So drugs and anaphylaxis in pregnancy. So what do you mean by anaphylaxis? It is a serious allergic or hypersensitivity reaction which is rapid in onset and may cause mortality, which is very important. And in pregnancy, it can be a catastrophe for both mother and fetus. The prevalence is 0.05 to 2%, and there is data regarding prevalence of this pregnant woman is very, very limited because the reporting is less. And the retrospective studies have found the rate of about 2.6 to 3 per 1 lakh pregnancies. Now, the clinical manifestations, maternal cutaneous symptoms, that can be just flushing, itching, urticaria, angioedema, including periorbital edema and conjunctival swelling. There can be a respiratory symptoms like nasal discharge, congestion, change in voice quality, sensation of throat closure or choking, cough, wheeze, and dyspnea. Gastrointestinal symptoms like nausea, vomiting, diarrhea, crampy abdominal pain. Cardiovascular symptoms like dizziness, tachycardia, hypotension, and collapse. So these can be a cutaneous, just we know that there is arterial rash here. And what are the potential problems which can arise symptoms during pregnancy? Just a low backache. Patient can enter into preterm labor, fetal distress, uterine cramps, and we should know there's vulvar and vaginal itching because these are the things where the mast cells are in abundant. So just it can start with the itching at the vulvar and vaginal area. Now, maternal and fetal effects, which affects this anaphylaxis, can affect the fetus in several ways. There can be maternal hypoxemia, which reduces the oxygen supply for the fetus. Hypotension reduces the uterine perfusion, which in turn reduces the oxygen supply to the fetus. Maternal alkalosis, which decreases the uterine blood flow by vasoconstriction and increases the affinity of maternal hemoglobin for oxygen, which reduces the oxygen supply for the fetus. Now, what is the definition and clinical criteria? The presence of at least one of the following. One is life-threatening airway problem, which is taken to include, there can be a laryngeal or pharyngeal edema, hoarse voice, stridor, or life-threatening breathing problem, which is taken includes shortness of breath, then wheeze, decreased oxygen saturation, confusion secondary to hypoxia, cyanosis, respiratory exhaustion and respiratory arrest, or life-threatening circulatory problem, which is taken to include signs of shock such as fainting, pallor or clammy skin, tachycardia, hypotension, then decreasing level of consciousness, signs of ischemia on ECG, and cardiac arrest. These can happen. So what can anaphylaxis and what is the risk assessment and the risk reduction? One is confirmation of anaphylaxis trigger, measure of allergen specific IgE, defer allergen skin test if possible. Avoidance and immunomodulation can be done, like avoid the known allergens during pregnancy, defer the medication desensitization if possible, substitute drugs from different classes, defer the initiation of allergen immunotherapy during pregnancy, and if possible, continue the maintenance immunotherapy without dose increase. Now, emergency preparedness, epinephrine auto-injectors, and training for the use. Anaphylaxis, you should carry a card, action plan, or education, and you should identify the triggers. So these are the very important during pregnancy. So identify the triggers. One is antibiotics such as ampicillin, cephalosporin, penicillin, anesthetic agents, even oxytocin, intravenous iron, we know it can cause anaphylaxis, misoprostol, anti-globulin G anti-D injection, breastfeeding, even breastfeeding can initiate any allergic reaction, laminarias and others like honeybees, yellow jackets, hornets, wasps, ants, shellfish, and peanuts or tree nuts. These all are the triggers for anaphylaxis. Antibiotics, we all know that antibiotics administered before cesarean delivery for prophylaxis against surgical site infection during labor. And these medication, we all know penicillin, ampicillin, cefazolin, and ceftriaxone. We have noticed ceftriaxone is very dangerous, and unless we know that the patient is allergic. So when there is a solution, is a medication, it can become a problem. Now, what about anesthetic agent? Medication used for the neuroaxial and general anesthesia can cause anaphylaxis. And even the anaphylactic reaction, what we thought of local anesthetic, are rare, and true allergic reaction account for less than 1% of all drug reactions to the local anesthetics. The most common immune-mediated reaction to the local anesthetic is delayed hypersensitivity reaction, or it can be a contact dermatitis. What about oxytocin? Anaphylaxis to oxytocin has been reported, and in some cases, the reaction may have been due to concurrent latex exposure, or in other cases, symptoms may have been attributed to chlorbutal, which is an inactive ingredient in the oxytocin preparation. So monitor therapy when oxytocin is given with ephedrine or haloperidol. Now, intravenous iron, we all know it is very, very dangerous. And that's why the safety of intravenous iron preparation has greatly improved nowadays. High molecular weight dextran, iron dextran had a higher incidence of anaphylaxis and shock, including fatal events. No longer nowadays it is used, and availability of safer intravenous iron formulations are always there with safety profile, higher safety profile, and it has lowered the threshold. Breastfeeding has been implicated as a trigger for anaphylaxis in several case reports, sometimes in association with the administration of non-steroidal anti-inflammatory drugs, which are also potential anaphylaxis triggers. Now, diagnosis, laboratory tests like serum tryptase levels, which are obtained within 15 minutes to 3 hours following symptom onset. Now, serum tryptase level time begin to rise as early as 5 minutes after the clinical onset of anaphylaxis, reaching maximum levels between 30 to 90 minutes, and then decline with half an hour, about 2 hours. Undetectable, normal and baseline levels are undetectable, less than 1 nanogram per ml in a healthy individuals who have not experienced anaphylaxis in preceding few hours. So baseline total tryptase level range from 1 to 11.4 with an average of 3 to 5 nanogram per ml, and elevated levels, marginally elevated to levels more than 100 nanogram per ml, which is significant. Now, plasma histamine levels. Now, peak within 5 to 15 minutes of the onset of anaphylaxis symptom, decline to the baseline by 60 minutes due to the rapid metabolism by N-methyltransferase and diamine oxidase. Blood samples for histamine require special handling, and histamine metabolites can sometimes be detected in the urine following anaphylaxis, and elevations are less fleeting than the elevations in the plasma histamine. So potential future tests, a lab test for the mature beta tryptase, which is a better marker of mast cell activation than the total tryptase, has been developed, although it is not widely available. Other potential marker of mast cell or basophil degranulation, such as platelet activating factor, cell carboxypeptidase, A3 kinase, and basogranulin are under investigations. Now, differential diagnosis is acute asthma, general urticaria, acute angioedema, syncope or fainting because of other causes, night attack, postprandial syndromes, pollen food allergy syndrome, that is glutamate reaction and sulfur.
Hello.
Flush syndrome such as carcinoid syndrome and certain tumor system capillary leak syndromes are other differential diagnoses. Now, just I wanted to tell something about the laboratory and the consequences. The pulmonary embolism and pulmonary edema, cardiac conditions, we have to differentiate hypertension because of other causes, cerebrovascular accidents, amniotic fluid embolism, preeclampsia, eclampsia associated symptoms, cardiac condition that place mothers at risk of decompensation include pulmonary symptoms. Things one should always remember that labor, whenever we are talking to patients in labor and delivery. The consequences, the case reports and small series of anaphylaxis during pregnancy generally show a good maternal outcomes, although the maternal morbidity and death have been reported. In contrast, the available reports, they suggest that the fetus and neonate is at risk of neurological damage or death, even when the maternal outcome may be favorable. So once there is a hypoxia setting, the fetal outcome is very bad. Now, the management, prompt administration of epinephrine is critical, which is considered as a drug of choice for the treatment of anaphylaxis in both non-pregnant and pregnant patients. Ambulatory or emergency department setting, intramuscular injection of epinephrine is the safest and most effective. Operative setting, epinephrine is given intravenous bolus or infusion. So I am epinephrine 1 milligram per ml preparation, 2.5 milligram, preferably in the mid outer thigh. You can repeat every to 50 minutes or more frequently as needed. Pheochromocytoma are at risk of excessive autonomic stimulation from adrenergic vasopressors. So patient receiving monoamine oxidase inhibitors are extremely sensitive again to vasopressor, therefore require much lower dose. So we have to be very cautious. So this is a chart where the treatment of anaphylaxis during pregnancy has been depicted. Have a written emergency protocol for anaphylaxis for recognition and treatment. Remove the exposure to the trigger if possible. Discontinue the intravenous medication. Assess the circulation.
Madam is having some network issues. Madam, you are muted. Yeah.
Yeah. I'm really sorry. I lost the contact. Shall I share it again? Only 3 minutes have left. So I'll just share my presentation again. Yes. I think my net was not working. Yeah. So I hope my screen is visible again. And we were talking about the treatment of anaphylaxis in short. So you have to be ready, call for help. Resuscitation team should be ready. Inject epinephrine, give high flow oxygen, then position the mother on the left side, elevate her lower extremities, maintain the minimum maternal systolic blood pressure of 90. Continuously monitor the maternal heart rate, blood pressure, oxygenation, and fetal heart rate. And whenever indicated, perform cardiopulmonary resuscitation with continuous chest compression, rescue breathing. And when indicated, perform emergency cesarean delivery. So this is the protocol which has to be followed. And other measures, bronchodilator, H1 antihistamines, H2 antihistamines, and glucocorticoids should be given. Bronchodilators should be given. If there is a bronchospasm, you can again repeat the epinephrine. Nebulization can be repeated with selective beta-2 adrenergic agonist. Now, H1 antihistaminic treat itching and hives, but these agents do not prevent or relieve upper or lower airway obstruction, and they do not prevent any relief shock. So simultaneously, you have to see that what is the condition, how is the condition of the patient, and these should not be used as an initial or the sole treatment. Now, diphenhydramine, that is 50 milligram intravenously, can be given to decrease the hives and itching if parenteral agent is desired. So, among oral agent, the second generation H1 antihistamines, that is cetirizine or loratadine, can be or also preferred. Glucocorticoid, methylprednisolone 1 milligram per kg IV every 8 hours or 2 or 3 dosages can be administered to the patient with severe anaphylaxis to reduce the risk of protracted anaphylaxis. So fetal monitoring is should be continuous, and these are complicated by anaphylaxis. We know that there is a hypoxia. So NST should be done. And if there is a category 2 or category 3, fetal heart rate tracing should be done. And that should be managed by correcting maternal hypotension and hypoxemia with aggressive maternal medical management. Emergency cesarean delivery should be done in these patients for the non-reassuring fetal heart rate tracing, which is unresponsive to the maternal and fetal resuscitative intervention. So emergency cesarean delivery should be done with anaphylaxis refractory to the medical treatment, need to be balanced against the potential maternal risk for surgery as well. And in an unstable patient with already there is a hypoxemia and hypotension. So you have to weigh both the risk. So there are various articles which are there on British Journal, and they have seen that the incidence, various characteristics and management and outcome of anaphylaxis in pregnancy. And they have found out that antepartum is really dangerous, and they found in antepartum period, there are various causes like various reactions to the antibiotics, or they have found in the postpartum also anaphylaxis to various, even 1 or 2 cases of for the syntocinon also. So mostly the cases for the antibiotics they have reported. Now, prevention is the identification, confirmation, and avoidance of the specific allergen triggers to which the patient is sensitive, including food, medication, insect stings, and natural rubber latex. So these are allergens, and pregnant women should be questioned carefully about the past adverse drug reaction. Yes, skin testing and graded challenges are generally avoided during pregnancy because of the small but definitive risk the procedure can induce a systemic allergic reaction. So emergency preparedness is the answer. You should have these auto injectors at your, if you're allergic. You can carry the belt also, which are shown here on the right side. They are allergic to some latex or antibiotics, so they should always put that for the pregnant woman. So at the summary and recommendations, anaphylaxis is not common during pregnancy, but you should recognize rapidly, treat it effectively, and there are 40 potential symptoms and signs. So you should be very careful to look at this anaphylactic reaction symptoms. So fetal asphyxia and hypoxic ischemic encephalopathy and death can occur with the fetus. So trigger of anaphylaxis, those are typically food, drugs, and insect stings. And clinical history taking is very, very important. That is what I must say at the end of my talk. Thank you very much for the opportunity. And thank you very much for everything, for including me in this talk. Thank you very much.
Dr. Niharika.
Thank you so much, Vidya ma'am. You covered such a vast topic in such a short time, and I feel it has really enlightened all of us because we have shortage of time and we are running little late. So we'll move to the next one, Supriya.
Yes. So thank you so much, the chairperson and Madam Vidya Thobi Madam. So next talk we have of Dr. Alka Pandey Madam. I'll just share the CV. May I request Dr. Indranil Roy to, oh, sorry. To introduce Madam Alka Pandey.
Hello. Yeah, a very good evening to one and all here. And at the outset, I'd like to thank Sneha ma'am and the whole ICOG team for this wonderful opportunity. Without much delay, I would like to request Dr. Alka Pandey. I think she doesn't need much introduction. She's the professor, Department of OBGY at Narayan Medical College, Sahana. She was a vice president, FOXY, 2022 to 2024, organizing chairperson of the FOXY Vice President Conference. And she was the past president of the Patna OBGYN Society. So, madam, she doesn't need any introduction. She is well known to all of us. And today she'll be speaking on blood transfusion reactions. So,
thank
madam.
you so much. Thank you, Sneha. Thank you, Supriya. And thank you all the organizing team for giving me this opportunity. So, Supriya, are you going to share the slides or I'll do my own?
You will do, madam. You will do.
Better you share from.
Okay. Okay. So my topic is blood transfusion reactions.
Can you make it full screen, madam?
Yes, yes, yes.
Yes.
So I'm going to talk on blood transfusion reactions. Any unfavorable event occurring during or after blood transfusion is blood transfusion reaction. Common causes of transfusion reactions are patient misidentification, improper sample identification, wrong blood issued, administration error, technical error, and storage error. Now, what are the types of transfusion reactions? Immune mediated, non-immune mediated. Immune mediated may hemolytic transfusion reaction, which may be immediate or delayed. Non-hemolytic transfusion reaction, which again can be immediate or delayed. Then non-immune mediated may be again immediate or delayed. So how do you classify it? We have already talked about this. So hemolytic transfusion reaction, these are very severe reactions and can be classified into two types. Immediate hemolytic transfusion reaction, which is intravascular hemolytic transfusion reaction, and delayed hemolytic transfusion reaction, which is extravascular hemolytic transfusion reaction. Now, intravascular hemolytic transfusion reaction, there is hemolysis of red cells within the circulatory system. Hemolysis occurs within few minutes of being started, that is within 24 hours. This type of reaction is mainly due to IgM antibodies, that is anti-A or anti-B, mediated by the rapid activation of complement and is usually associated with transfusion of ABO-incompatible blood. Symptoms are fever, chills, hypotension, chest and back pain, nausea, dyspnea, vomiting, hemoglobinuria, acute renal failure, and pain at transfusion site. Now, management. As soon as you detect there is reaction, you have to stop the blood transfusion immediately. Mannitol is the agent used to prevent renal failure, and to treat hypotension, you have to give intravenous fluids and vasoactive drugs such as dopamine. So delayed hemolytic transfusion reaction, that is extravascular, and these are rarely severe and mainly due to IgG antibodies, that is Rh, KEL or Duffy system. These antibodies bring about the destruction of red cells by the macrophages in the spleen or liver. Hemolysis occurs after few hours or after about 3 to 7 days of transfusion. Now, IgG antibody coats the RBC and sensitizes them. Sensitized cells interact with the phagocytic cells, which engulf the sensitized RBC and destroys them. So this is the same thing depicted in diagram. IgG antibodies coated red cells. They interact with receptors of phagocytic cell. Phagocytic cell engulfs the antibody coated cell and incorporates it into the intracellular vacuole. Lysis of red cells within the intracellular vacuole of phagocytic cell occurs. Delayed hemolytic transfusion reaction could be due to primary alloimmunization or amnestic or secondary response. Now, this response to transfused RBC occurs in patients who have been previously sensitized by transfusion or pregnancy. Level of incomplete antibody is low, cannot be detected by standard pre-transfusion procedures, and there will be increased antibody production resulting in red cell destruction. So there'll be a fall in hemoglobin, rise in bilirubin, mild jaundice within 5 to 7 days of transfusion, and renal failure is rare. Non-hemolytic transfusion reaction can be classified as febrile non-hemolytic transfusion reaction, urticarial transfusion reaction, anaphylactic transfusion reaction, non-cardiogenic pulmonary edema, circulatory overload, and graft versus host disease. Febrile non-hemolytic transfusion reactions are the most common and account for over 90% of transfusion reactions. These are benign, self-limiting reactions due to the presence of antibodies to WBC or platelet antigens and are usually seen in multi-transfused patients. These occur within minutes of starting the transfusion. Due to presence of anti-leukocyte antibody and antibodies to platelet in the patient's serum, it may be due to past transfusion or pregnancy. Antibody reacts with donors' WBCs. Antibody and antigen complex activates the complement system and releases of pyrogens from WBCs results in rise of temperature. Signs and symptoms are fever, chills, and malaise. So the therapy and prevention is give leukocyte poor red cells. Antipyretics can be given before starting transfusion, but they must be avoided as much as possible as they mask the transfusion reaction. No evidence of hemolysis in post-transfusion sample. No red-pink plasma. Direct Coombs test is negative. No increase in bilirubin and no hemoglobinuria. Urticarial transfusion reaction. This is immediate hypersensitivity reaction. Allergic signs and symptoms appear within few minutes of exposure. The donor's plasma contains allergens which react with reagent present in patient's plasma, and the donor's plasma contains reagent that combines with allergens in the patient's plasma. Allergen reagent complex attaches to the mast cell surface and releases histamine. Local erythema. There is local erythema, pruritus, hives, hypotension, loss of consciousness, and shock. One has to give antihistamine for this. Now, anaphylactic transfusion reaction, already Dr. Vidya has talked about this. This is a severe life-threatening reaction which occurs in rare patients who are IgA deficient and have developed anti-IgA antibodies. These reactions developed quickly within minutes of starting the transfusion. And signs are respiratory tract is disturbed, cough, bronchospasm, and dyspnea occurs, nausea, vomiting, diarrhea may be there, and severe hypotension, syncope, generalized flushing, and urticaria is present. Therapy and management is you have to keep the IV lines open with normal saline, inject epinephrine, inject antihistaminics, and give oxygen by mask to correct the hypoxia. Transfusion-related lung injury, that is TRALI, also known as non-cardiac pulmonary edema, altered permeability of the pulmonary capillary bed by activation of complement, histamine-mediated events, or prostaglandins, and this leads to fluid accumulation, inadequate oxygenation, and reduced cardiac return. There is acute onset of respiratory distress, dyspnea, cyanosis, fever, and chills. You have to give oxygen. You might have to intubate the patient. Intravenous steroids and leukocyte poor component can be used. Post-transfusion purpura occurs with platelet concentrate transfusion. Rapid onset of thrombocytopenia due to production of platelet alloantibodies, usually in multiparous female. Duration is 7 to 14 days from transfusion, and therapy is corticosteroids. Graft versus host disease, complication of blood component therapy or bone marrow transplantation. Patients at risk are lymphopenic patients, bone marrow suppressed cases, fetus receiving intrauterine transfusion, newborn infants receiving exchange transfusion, and congenital immunodeficiency syndrome. Signs and symptoms are fever, rash, diarrhea, hepatitis, liver dysfunction, bone marrow suppression, and it may be fatal. And therapy is with corticosteroids and prevention. Non-immune, non-hemolytic transfusion reactions may be immediate, that is due to bacterial overload and circulatory overload, and delayed is iron overload. Bacterial overload is due to bacterial contamination, due to toxins, and antibiotics can be used for therapy. Circulatory overload is more volume of blood transfused, fast rate of blood transfusion leads to congenital heart failure, pulmonary edema, chest pain, cough, and hypertension may be there. Long-term complications of RBC transfusion is one of the complications is iron overload. This is also known as hemosiderosis. The iron is accumulated and it affects functions of heart, liver, and endocrine system. The signs are muscle weakness, fatigue, weight loss, mild jaundice, and anemia. So you have to check all the records to ensure that the correct unit of blood was transfused to the right patient. And this includes the patient's details, blood requisition form, compatibility report, and labels. Examine the patient pre-transfusion and post-transfusion plasma from EDTA sample for evidence of free hemoglobin or increased bilirubin. Pink or red discoloration in post-transfusion plasma indicates the presence of free hemoglobin due to red cell destruction. Yellow discoloration of the sample drawn 6 to 8 hours after transfusion indicates increased bilirubin. Direct Coombs test is performed on the pre and post transfusion sample, and a positive test usually indicates the presence of recipient's antibodies on the surface of donor red cells. However, if all the cells have been already destroyed, the test may be negative, and urine should also be checked post transfusion. And the first sample, if nothing is abnormal, indicates that no acute hemolytic reaction has occurred. And if any finding is positive or clinical findings strongly suggest a hemolytic reaction, the following investigations to be done. Repeat the cross-match testing both pre and post-transfusion sample of the patients against the sample from the bag by saline, albumin, Coombs techniques. Repeat antibody screening and identification of patients pre and post-transfusion samples. Thank you so much.
Thank you, Alka ma'am, for such a detailed talk on blood transfusion. I think as obstetricians, we need to understand this topic in details because in its day-to-day practice, we are using blood transfusion and we need to know the side effects so that we can deal with this properly. And thank you once again, madam, for this wonderful and excellent deliberation. Over to you, Dr. Supriya.
Thank you, Alka ma'am, and thank you, Dr. Indrani Roy, for this wonderful session. Now we move on to the next topic.
Thank you, Alka madam. Thank you so much for the wonderful deliberation. Thank you, madam.
Thank you so much.
So we move on to the next talk. And for that, I'll just share the screen.
Can I share the screen or a little later?
No, just may I request the chairperson, Dr. Pushpa is there. Kindly introduce the speaker.
Welcome, Ritu. Good evening.
Hi, how are you?
I'm fine. Come. Is
Working very hard.
here? Yes, that is what we enjoy, working hard. Is Pushpa madam there? Or
Yes,
maybe
yes,
I will
yes.
just.
Yes.
Yes,
Yes,
yes, madam.
I am very
Good
much here.
evening. Good
First of
evening.
all, I would
Welcome
like to
back.
congratulate Dr. Sneha for having this wonderful and highly useful, informative ICOG
Thank you, madam.
Obstetric Emergencies online certification course. I welcome Dr. Ritu Joshi. Everyone knows her. She is senior consultant at Fortis Escorts and Surya Hospital, Jaipur. She was Vice President Foxy 2014, Chairperson Family Welfare Committee 2009 to 12, and she is faculty in various national and international
I
conferences.
think enough, Sneha. We're wasting time.
Yes, yes, madam. We would like to hear from
Yeah,
you.
This much is
thank
enough.
you so much.
Please go ahead.
So madam can share your screen.
I'll just start sharing the screen.
Yes, madam.
Yes, ma'am. Oh God, now you'll have to guide me.
Yeah, you click on the icon, the share screen at the bottom.
I've
At the
come to
bottom
share
of your
screen.
Click on share screen. Yeah, it's coming. Now
And
the
now?
no, the Zoom window has opened. Have you not opened the presentation, the PPT?
You want me to open that first?
Yes, yes. You minimize this or you close this. Just open your presentation and then share screen.
Yeah, I'll just do that.
Yes. I can see now your screen.
1 minute. And let me get onto the slideshow.
Yeah.
Now, where is the slideshow? Okay, let me do it
On
this
the
way.
right. Yes, yes. On the lateral side. Yes. Next to it. Next to it. Yeah. Yes. Perfect.
Okay, now I can carry forward.
Yes, go ahead.
I'm audible because we have a lot of network issues. So I might be inaudible in between.
You are
Okay, so we are going
audible
to
and well visible, my dear.
Good evening, everyone. And thanks to Sneha for inviting me on this webinar. It's a very interesting topic of DIC in pregnancy. Now, this is a life-threatening thrombohemorrhagic condition. Well, actually, if you see, medically more common in men, but in women, apart from the reproductive years, which during pregnancy, it is quite prevalent. It constitutes one of the leading causes of maternal mortality worldwide. And this almost ranges from 0.03 to 0.35, which is quite a wide range from different countries. And it is often secondary to any of the underlying maternal fetal complications, which we already know. So just a definition given to us by the International Society of Thrombosis and Hemostasis. It is an acquired syndrome characterized by the general intravascular activation of coagulation with loss of localization arising from different causes. It can originate from and cause damage to the microvasculature, which if sufficiently severe can even lead to organ dysfunction. So it's that severe. But DIC is not a disease. It's just an entity on its own. So from this definition, we find out that there are three important aspects. It's always secondary to another cause, and it represents systemic pathological activation of coagulation and is a process which originates in the microvasculature or the vascular epithelium. So it's a syndrome of abnormal coagulation and fibrinolysis. Consumption coagulopathy is a disorder marked by reduction of the blood concentration of platelets due to exhaustion of coagulation factors in the peripheral blood, resulting in DIC, which occurs in response to certain obstetric complications. So there are three different types of DICs, which are not important for us. I've put it up because of the academic importance. Epidemiologically, I have already spoken about that it has a good range of 0.03% in North America to 0.35% in developing countries. It is always secondary to an underlying disorder, which we know could be in the form of placental abruption, IUFD, HELP syndrome, preeclampsia, most of them which PPH, and these are the proportion of the contribution of each risk factor varies among the countries. That is why we find that all these obstetric causes are there which lead to DIC, or DIC is because of them. We also can have the obstetric and differentiated into obstetric and non-obstetric causes. We know that amniotic fluid embolism, placental abruption, placenta previa and accreta, PPH, HELP syndrome. And in the non-obstetric, we have sepsis, trauma, organ damage, leukemia, etc. So with a lot of studies done in different countries, we found that different countries had different DIC causes, which were important. Like in our country, it is more of PPH. In some countries, it was abruptio placentae. In the few of them, it was preeclampsia, acute fatty liver of the disease, and all that is there. So these are the global distribution of the obstetric causes. DIC could be acute as well as subacute. And in acute, we have three main causes, which is abruption placenta, amniotic fluid embolism, septic abortion. And in this, there's increased bleeding, there is decreased organ function, consumption of coagulation factors is noticed, there's prolonged PT and APTT, there's thrombocytopenia, fibrinogen might be normal or reduced, FDP is elevated, and fragmented RBCs are seen on the smear. While in subacute cases, which is preeclampsia, the HELP syndrome, and retained dead fetus, no symptoms are there, no measurable consumption coagulation factors, normal PT, APTT could be there, FDPs might be normal fibrinogen. And before we proceed further, we must know about DIC. What is the pathophysiology? Unless we understand the pathophysiology, it's going to be difficult for us to understand how do we manage DIC. So it has a complex pathophysiology. Now here only we are complexed. Understanding the normal hemostasis and the highly orchestrated balance involving the various pathways, including the procoagulant versus anticoagulant, the fibrinolytic versus the antifibrinolytic, and the platelet and the von Willebrand factor axis in pregnancy is essential for the hemostatic abnormalities observed during the pregnancy. Now, in a normal pregnancy, there's expanded plasma volume and there's physiological anemia. There is obstruction of the venous pattern is seen in supine position after 20 weeks of gestation. Hypercoagulability is there, that during pregnancy there's increase in lot of clotting factors, concentrations like factors 7, 5, 2, 8, 9, 10, and 12. The plasma fibrinogen level also significantly increased during normal pregnancy. And there is a small decrease in the platelet count due to the low grade intravascular coagulation. So plasma fibrinolytic activity is suppressed during pregnancy and labor. Always remember this, and it returns to normal within 1 hour of delivery of the placenta. This is due to the liberation of plasminogen inhibitors from the placenta. So this is the systematic representation of the pathogenic pathway of DIC, and it's very clear that there is fibrin deposition which collects and leads to the clot formation, and there is the DIC. Now, diagnosis of DIC in pregnancy, it is actually the hallmark of successful management of this dire complication. And this depends upon the prompt and accurate recognition of DIC. There is no single lab or clinical test that is sensitive and specific enough to the diagnosis. The risk to develop DIC is not evident in all the cases. So, wherever we are suspecting, we know the obstetric causes, we must be vigilant after those patients deliver or when that happens. DIC is a dynamic situation that requires a continuous assessment of the clinical signs and symptoms. And what are those we need to be careful about is decreasing concentration of fibrinogen and platelet count, prolongation of the prothrombin time, and increased concentration of fibrin split products or the D-dimer until it resolves. And that also we've got to monitor till they come back to the normal. So there is a need to develop means for early diagnosis by the clinicians. There is also a need to establish a universal definition of DIC in pregnancy. Use of DIC scoring system has been established by the society, but none of the scores are adjusted to the physiological hemostatic changes occurring in pregnancy. So their use is limited, but let me say, figure it out here. that DIC related causes, if they are there, then order coagulation test for the patient, do a prothrombin time, platelet count, fibrinogen level, fibrinogen degradation products. If it is not there, then there's no use of using this table. If we find the prothrombin time, the platelet count, the fibrinogen level, and the fibrinogen degradation products, they all have a score which is given to them. And in the end, when we take the total score, if it is more than 5, it is less than 5, sorry, it is compatible with more than 5, sorry, it is compatible with the overt DIC. That means you must keep repeating the scores again and again daily. And if it is less, it is suggestive of a non-overt DIC. Now, women with a normal pregnancy have excessive thrombin generation, increased agonist derived from the platelet aggregation. There are 2 to 3-fold increase in the fibrinogen concentration. And towards term, they experience almost a 20% to 1000% increase in factors 7, 8, 9, 10, and 12, as well as up to 400% increase in the von Willebrand factor. By contrast, factor 13 and factor 11, concentration decreased during the gestation, and that of the 2 and 5 remain unchanged. So what is the basic treatment of a DIC? Now, the basic treatment is prevention, early diagnosis, and then coming to the treatment part of it. Prevention is identification of the patients at risk, then active management of the 3rd stage of labor, and prompt diagnosis and management of obstetrical complications that may be associated with development of DIC, even in the absence of labor. What is the treatment? The basic principle of that is that treatment and resolution of the underlying condition leading to DIC, fast and prompt delivery or termination of pregnancy, supportive treatment of the blood product transfusion should be there, surgical management and related measures should be taken, rigorous clinical and lab surveillance should be there, prompt involvement of other consultants. So it is actually a multidisciplinary team should be involved in it. And in a small size or a medium size, healthcare centers, we should have either connections with the higher centers for the repeated massive blood transfusions, which we are going to have, and or we transfer the patient to a higher center. So we look into the obstetric causes, and then if they are there, we do the prompt delivery, administration of blood products, then treatment of the underlying cause, repeat the lab testings. And if it is not there, then obviously we should do the clinical and lab assessments if we are suspecting it. And if it is low risk for DIC, we finish off there and then. And if it is a high risk, then we must have a multiple disciplinary team as well as the lab investigations. Now, there's a very small thing which came to my notice. And then I remembered that even in our hospital, I work in a tertiary care center. And we have this because we do renal transplants and liver transplants in our setup. So this is viscoelastic hemostatic assays, guided perfusion protocols. And if we do it according to this protocol, it's very simple way of giving how much FDP is to give, how much of whole blood or whatever. So during DIC, there's a rapid consumption of fibrinogen and coagulation factors, making the monitoring and maintenance of proper blood product administration by conventional lab testing. The ROTEM/TEG allow early detection and dynamic monitoring of the clotting abnormalities and transfusions needed. So if we are using that method, then this is how we would follow this logarithm. But unfortunately, most of us do not have. I just wanted everyone to know about this new entity which is there. So what exactly are the things which we do in the management of DIC, of the coagulopathy? That is antifibrinolytic agents like trinasmic acid. It is an adjuvant to the blood product administration, prevents activation of plasminogen by plasmin by blocking its lysine binding sites. And the usual dose is 1 gram intravenously over 10 minutes and up to 4 times a day it can be given. The other, which is now the new kid on the block and now has been, we've been suggesting a lot of recombinant activated factor 7. And I had used it way back in 2017. And if my friend, 2014, sorry, when a physician suggested it to us in one of our cases, But if Dr. Ganatra is present at present, then he has used it rampantly in a number of patients. Warranted and active obstetrical hemorrhage. Now, always remember that this also should be given at the right time, not when the platelets have been consumed and then you're giving the factor 7. So optimal use requires exclusion or correction of metabolic acidosis, hypothermia, hypofibrinogenemia, and thrombocytopenia. Optimal dose is unclear, but the highest dose is 90 micrograms per kg and can be used if patient is unstable or the blood loss is brisk or ongoing. The other thing, entities are there, which is fibrinogen concentration. Then there is this desmopressin, which is there, recombinant human soluble thrombomodulin, then anticoagulants. Now, as far as DIC is concerned, we know that it's an hemorrhagic type. So we do not use the low molecular weight heparin or any heparin in this. So now what I would suggest is that we have a timely diagnosis to prevent it. We have a good recognition and we have lack of redefined protocols or checklists. So we must make the checklists and all. Now let me put an example quickly here. The major causes of maternal deaths we find is hemorrhage. And there was an interesting study in 2015 in Canada, which said that the pregnancy-related mortality in California causes characteristic and improvement opportunities. And in this, they found that there was a good to strong chance to alter the outcomes of 41% deaths, with the highest rate of preventability among hemorrhage, which is 70%, and preeclampsia, which is 60%. So now if I have a patient of PPH and who goes into DIC, we know that the causes of PPH are the 4 T's. I would like to add over here the 5th T, and that is to transfer the patient to the theater. The 4 T's are the tone, trauma, tissue, and thrombus, and the massive blood transfusion it needs. And there is massive transfusion, there is hemodilution. We have to be careful of the hemothermia, hypothermia, as well as the acidosis. So this is again the same I'm showing over here, how we are going to manage these patients. Now, in a massive obstetric hemorrhage, the coagulopathy is there and coagulation profile needs to be done every 4 to 6 hourly. You see the thrombocytopenic rashes coming up. You see that the urine output is decreasing. Now, how do we manage her? The linchpin in the management of the obstetric hemorrhage is evacuation, which we spoke earlier, the medical treatment, the surgical management, and the management of PPH, targeted resuscitation, targeted blood and blood component therapy, as well as trinasmic acid, cell salvage, factor 7, and also the POCT. Now, this is a very interesting classification in which we see that we can judge the amount of blood loss, because we know that during pregnancy, the patient has a lot of storage and a lot of capacity in her, that if there's a blood loss of almost 15%, she falls into class 1. The pulse rate remains to be less than 100. We find her, she has a normal pulse pressure. Her BP is normal or slightly increased. While in class 4, we find that the loss of blood loss is more than 40%. There's tachycardia, the pulse pressure is decreased, and even the BP starts decreasing. So remember, an increased physiological reserve in pregnancy was there. So a blood loss of more than 1000 ml, 15% loss, they are asymptomatic, sorry, less than 1000. If it is 1000 to 1800, there's tachycardia, orthostatic hypotension, 18 to 2000, worsening tachycardia, tachypnea, as well as hypotension, and more than 2200, they are in shock and oliguria. So we must see how much the blood loss the post-delivery was. Even the sponges, the sheets all around should be taken into account. And now, how do we manage her? We have to maintain the circulation by giving the blood and the blood products. We've got to stop the hemorrhage by looking around for any site. You know, the surgeon working on the perineal region should need to work on stoppage of the hemorrhage. We know about the shock index, has already been spoken about. And now, which fluid should we give to these women who are in DIC? Do we give crystalloids or we give colloids? A lot of research work has been done, assessment of hemodynamic efficacy using either the colloids or the crystalloids. And ultimately, we find that the crystalloids are to be used. In women with massive obstetric hemorrhage followed by DIC, our approach in our hospital, we've kept it as hypovolemic shock, prevent, proactive. The multidisciplinary team should be there. Start the crystalloids in the form of ringer lactate or plasma light, and they should be warm fluids because the patient's temperature is already on the lower side. Lower molecular weight starch preferably to be avoided. Permissive hypotension should be there. Avoid critical drop in hemoglobin and assess and procure the blood as early as possible. The evidence and experience-based approach gives us a better this thing. And we must also remember that the normal oxygen delivery to the tissues required is around 1000 ml per minute. That consumption by the tissues is around 250 ml per minute, and oxygen extraction ratios by the tissues is around 22 to 30%. So we must give them oxygen and we must give them the red cell transfusion. We have to balance a strike. Not more is not necessarily better. Even too little, too late is dangerous. We must most of us have this HemoQ to measure the hemoglobin in our clinics. We can use them in our labor rooms also, instead of taking out a sample, sending it to be done and all. And we already have the monitor. So the hemoglobin should be done and the ST depression should be seen. The patient should be given 2 large bore intravenous cannulas and avoid inotropes. The aim is to adequate volume replacement. And this is how we go about monitoring our patients.
2 minutes.
And then we must see the temperature of the patient, monitor the temperature as well as the urine output. Coming to the transfusion goals, our massive transfusion protocol is 1:1:1:1. And the role of we give whole blood or we give components needs to be thought over. Or do we need the role of NAT tested blood or role of factor 7? Well, remember always that the PRBCs and the whole blood, the hemoglobin rises by 6%. In the random platelets, we find that random donor platelets, we find that the rise is by 75,000. In the single donor, we find it is better option than the random. And we do give cryoprecipitate as is required. The
Sorry to
transfusion and the
interrupt,
points to
madam.
remember.
Already, madam, sorry to interrupt.
Just
Actually,
finishing
5
it
minutes.
up. Just finishing it
Okay.
up.
Okay.
Hemoglobin at 8 gram%, hematocrit at 25, PT, APTT should be 6s of the Cs, and the platelet count should be around 50,000, a little more than that, and fibrinogen less than 100 micrograms. So this is how we manage our patients, giving them. And newer modalities, I spoke about renasmic acid earlier, the cell salvage, the recurrent factor 7A, and the POCT with the tag, and the post-resuscitation organ protective supportive care in the ICU should always be there. There are a lot of drugs which we've already spoken about. Should we give them or should we not give them? We have to take care. If we understand the primary and the secondary hemostasis, we'll be able to understand that the platelet plug is formed by adhesion, activation, and aggregation. And then it is made firm and stable. So that's where tranexamic acid plays a major role. And that's where the factor 7 will also play a role in it. So we have a lot of studies there. A new entity, the cell salvage. A lot of people don't have it, so I can skip it over. Just that salvaging lost blood from the surgical site by using a surgical suction can also be used in the same patients, given only by washing up the saline, the RBCs with the saline. And it is cost effective or not, which higher tertiary centers would have it. Of course, the recombinant factor 7 is there. We all know about it. So diagnosis of severe PPH, medical, surgical, conservative management, blood components, first dose of, we can give, instead of sending the patient for surgery, it's better to give her the recombinant factor 7 nowadays in 90 micrograms per kg IV fluid. And the causes of failure are, if it is fibrinogen is less, platelet are less, there's acidemia, there's low body temperature, please do not give them. So friends, that's thromboelastography. If we have it in our hospital, we know how to use it by that logarithm which I had shown earlier. And So newer options we've already spoken about, and efforts for saving of life dependent on the price that the society has decided for that life. The risk management strategies, anything can go wrong, anywhere will go wrong. We must be prepared for all the facilities. Remembering that DIC in obstetrics is life-threatening and the diagnosis is very elusive during pregnancy. Always remember the obstetric reasons or conditions which lead to DIC and be vigilant in treating them. Thank you very much.
Thank you, ma'am. So
Any
wonderful.
comments by Chairperson, Madam Somunshi?
It was very informative talk, in spite of the DIC topic being very, very difficult to understand.
I know.
Madam made
I
it very
know.
easy.
Yes.
Thank you, madam.
Thank
So-
you. Covering
Thank you.
a vast topic and made it, quite simplified. Thank you so much.
Thank you, ma'am. Yeah. So we move forward, and now
Yeah, a very good evening to Madam Jayam Kannan, Madam Pranam, and we welcome you for this program. Do we have the chairperson to introduce, Madam?
I think Sneha.
Yes, Madam.
Everybody knows me well.
Yes,
so
yes,
we'll go
that
to
is
the
what,
topic.
in fact, I was about to say that
Yeah. Thank
everybody knows you, Madam,
Let
and
me
you are
share my
all
screen.
of us are blessed to
Thank
have you here. That's all.
Let me share my screen.
Yes, please.
Madam, just one word.
Yes.
Madam Pushpa, ma'am, just to introduce Madam Jayam Kannan.
It's okay. Madam will make comments after her talk.
We would like to have
Madam is
yes,
more
just
from
I will
her.
tell one minute. Madam is
Hi,
Foxy
Dr.
Adolescent Health
Janam. Nice
Committee.
to see you,
Nice,
Janam.
Madam is a
Long
yeah.
time.
Yeah. All
Very
of us
well
are happy
known.
to see each other. Thank you very much.
Madam was also the recipient of the Best Committee Award when she was the Adolescent Health Committee chairperson during her
Fantastic.
tenure. And Madam has done lots and lots of work during her tenure. So, Madam.
Yes.
Over to you, Madam. We are eager to listen.
Thank you. Thank you.
Thank you.
Right. My topic of amniotic fluid embolism is so fluid, and it is a mixture of what Vidya Dobi talked and Ritu Joshi talked. So two scary topics, and not only the patient is scared, the obstetrician who is standing there, the team, will have their eyes focused, pale, their pulse rate will be going up to tachycardia. Some even juniors can have a troubling, dressing, tremory hands. I have had the bad opportunity of treating a term primary, fainting in the OP toilet, cyanotic. That was the only thing. Immediately shifted her up to the theater in the next 30 seconds. Luckily, the anesthetist was finished. The earlier case was there. Nothing else was prepared. This thing was taken, a knife was taken, and he started the drip and he started the work. We delivered the child. Shifted her to the tertiary care center. 35 days she was there and she has come back. Now it is 30 years she is with me. That is the case which has probably led me down to talk about this scary topic. Amniotic fluid is part of the gestational tissue and it is very useful in pregnancy. Why not we have it continuously? And we also now we say it is a old statement. Now we say it is a multipotent cells. It can produce so many immunosuppressive property cells and other things. We are preserving it. Why don't we preserve it in our body? We cannot allow it to be in the body because in the body it is in a compartment. But when you expose the compartment to the maternal or fetal by any tear, the vasoactive proagulant factors in the amniotic fluid are going to cause extensive damages for you. The compromise, even though we know well the fluid is from the fetal part and it is kept as a buffer in between the mother and the fetus with the balance of the osmotic gradients entering into the maternal circulation is a havoc. As it has been defined, it's a tear in the medicine and entry into the maternal circulation, mostly into the pulmonary vessels, caused by a rent in the membranes, hypertonic uterus, when there is any excessive oxytocin administration, and any laceration of open vessels at any time leads on to this. Proud to say that Indian Journal of Clinical Pharmacology in 2016 has brought out a very good article. I would like you to note this article and go into it, every detail of it you get. It is the entry of the amniotic fluid into circulation, resulting in physical obstruction of the pulmonary circulation. Hypothesizing entry causes active inflammatory response because they have got so much of cytokines and immunokines. The causes of this, all of you please note, when you are seeing a multifetal pregnancy, polyhydramnios, placenta previa, accreta, and abruption, or when you are inducing a labor and you are trying to be bold enough to do a forceps delivery, or occasionally there is a uterine rupture, and even in your cesarean section, or when you have a tear in the cervix in any cause of this thing, and when your uterus is showing hypertonicity, please know that you are going to be in danger. What happens after the amniotic fluid with the deposit enters into the pulmonary circulation system, it immediately activates the fibrinolytic system, converts all the factors which has been told by Ritu Joshi, and finally, after the primary fibrinolysis, secondary fibrinolysis also settles in. What happens? Severe clotting defect, profuse bleeding per vagina, even through all the sites, even if a small injection has been, that starts pouring out. And what happens? Consumption coagulopathy follows. Clark is one person who has done a lot of work on it, and he has put it as a theory, phase 1 and phase 2. In the phase 1, what he tries to say is it's only the biochemical changes which are there in the right side of the heart and in the lungs with a vasospasm and hypertension. If you are not able to care it at that stage, it goes into the second stage, that is phase 2, where the left ventricle comes into action with the pulmonary edema, resulting in severe DIC and a massive hemorrhage. The second phase, once the patient reaches, it becomes very difficult to read this one. So with all this thing which we have talked, when all you can get amniotic fluid embolism, during labor, during LSES, vaginal delivery. Nowadays, please note, with 24 weeks of termination of pregnancy, you can get second trimester also. And it can be up to 48 hours after delivery. The clinical features of this is, the first one is patient may do a little cough. She may get a little fainted. Decline in all your pulse oximetry values. What was doing at that time was different, looking at cyanosis, but now the SpO2 and pulse rate, everything shows changes, and coagulopathy immediately starts. Patient can go in for fits. Second phase results in cardiac failure, pulmonary hypertension. At the same time, the fetus, if it is there in situ, it is going to have a fetal distress also. Of course, at this time, the main action is management, but however, we have to know theoretically the diagnosis can always be supported by blood parameters, ECG, echocardiogram, radiology, whatever is possible, arterial blood gas, and serum tryptase is the most important hallmark. The classic features of amniotic fluid as per SMF of 2021 is hypoxia, hypotension, coagulopathy, not to speak of any jaundice or bilirubinemia. But however, 2023 Medscape has made it very categorical that you should be very careful with hypoxia, hypertension, and other things. There should not have been any fever in that patient exceeding 38 degrees at the time of onset of labor. This is very, very important to be noted in all our case of AFV. The diagnosis is always by the history only. If possible, little coagulation test, and with exclusion of other things. What are the things we are going to exclude? What all Vidya Dobi was saying, with pulmonary embolism of air and other things, peripartum cardiomyopathy, max of toxicity if you have been treating an eclampsia patient, and ascending spinal shock in cases where you have been doing a cesarean and you get a AFE. The management is first a life support. Total life support, as has been said by Vidya. And mechanical ventilation is the next one. Then you have to have the saline, arteriovenous line, everything ready. At the same time, check if the baby is okay. Nowadays, it is not perimortem cesarean section. It has to be delivered as per the guided ones. The guidelines I will come to you soon. The goals of the care. Once you see the patient is surviving after you give epinephrine, maintain the blood pressure systolic, urine output, arterial PO2 60, correct the coagulation abnormality as told by Ritu, and maintain the uterine tone, which is very, very important, which is not there required in cases of just a DIC only. Practically speaking, how are you going to do? The minute you saw the patient is having all these problems, start a big bore IV line, call for help. Next, start epinephrine, corticosteroids, dopamine. In epinephrine, I will come to that. Somebody has asked what is epinephrine auto. Then start central arterial line if you are used to. Tranexamic acid, immediately. Endotracheal intubation, airway, continuous monitoring or recording is the first phase with any junior doctor who is there in the duty must do with all these things. Then her part is now, by the time the physician would have come, her part is to manage the uterus. If the baby is not delivered, deliver the baby. After delivery, massage, pack the uterus, give adequate oxytocin. If you are going to think of prostaglandins, give it with care. Epinephrine. Epinephrine is the first drug of choice, 1 milligram every 2 to 4 minutes. If the pulse rate, cardiac arrest does not return back within 4 minutes, prepare the patient and deliver the baby. What is epinephrine auto is there outside the country because everybody is prone for any anaphylactic shock. You carry the epinephrine auto with you, and there are two this thing packs in that, and the details are given in it for use. Corticosteroids is a drug of stress dose, and it is a must in all cases of amniotic fluid embolism. F-choline is the standard name, we call it 100 to 200 milligram to be given repeatedly. Once the patient is getting stabilized, we change it over. Then third drug we have to give is dopamine in the drip, 2.5 microgram per kilogram. At the same time, always monitor with the CVP also. The fluid load has been talked by Vidya and Ritu. Here, the 1:1:1 ratio of fat cells should be maintained. The fibrinogen level to be maintained critically is 150 to 200 milligram per dl. Now, patient is delivered. She is profusely bleeding. What do you have to do? Give oxytocin, methogen, carboplatin, recombinant factor 7, tranexamic acid, and lastly, if required, hysterectomy also. Here, we don't think whether methyl ergometrin can be given, carboplatin can be given. All those negatives, provided the patient doesn't have hypertension, all those indicators are not there. It is an emergency, you can use the drug. Now, the patient is to be shifted only if she is stable. Do not try to push the patient to the next center. On the way, she will collapse. The prognosis in this patient by 2010 was 50% die within 1 hour. Another 37 patient, totally 87 to 88 patient will die in the next 5 hours. But presently, with all the ECMO support and other things, we are able to save up to 25% of the patients. However, these patients can always go in for oliguric, cardiac, arrhythmias, and neurological problems. Baby also nowadays are able to survive up to 70%, which was not there. Subsequent pregnancies have also been reported in these cases. Death is always due to cardiac arrest, DIC, and respiratory distress. DIC, if it is managed appropriately with adequate tranexamic acid right in the beginning, it should be able to support you well. Just for information, if you are able to do an echo, because all of us now have got the scan machine, if you put it on the patient with the AFB, you will see the right side, the right ventricle as a D shape, which also can give you little this include to the diagnosis. Lab values are already noted. The best value to as a marker is serum tryptase, which has to be taken. Nowadays, we don't call it as a perimortem cesarean section. We call it as a resuscitative hysterectomy, pivotal in AFB management. And this is mainly to improve the maternal hemodynamics. The minute you take away the baby, right goes the center, gets gushed with the venous return. The heart should be able to function better. But in a time-sensitive areas where AFB is being managed, it is quite difficult to follow this. Now, when do you deliver the baby? In all cases, right at 10 weeks, you say an amniotic fluid embolism will do? No. At 23 weeks and after, 28 weeks and 32 weeks and thereon, anytime. 20 weeks, you don't require a delivery of the baby to manage the amniotic fluid embolism. Now, the medico-legal pitfall in all these cases are going to be faced by the doctor unless the patient has understood you very well. failure to recognize the emergency, failure to deliver the baby as it has been given by the recent testing, failure to think of this in all your cases of termination of pregnancy after 20 weeks. Please note that now you are liable for this problem. Autopsy, will it help in these patients diagnose Cori AFE? Even in normal cases, we have seen fetal cells in the circulation. So autopsy is not a clinching diagnosis as it was told in the last century. Now to conclude this topic, amniotic fluid embolism is catastrophic, unpredictable, unpreventable, untreatable in all cases. Only in few cases you can see it, provided you are having a high risk delivery unit, as Ritu Joshi is having it, where you have got all the people to support you. Need not go for call for help. And everybody is there, cardiorespiratory unit, transfusion unit, theater, everything is just at the bedside of the patient. You should be able to make this 75%, 25% survival to 75% survival in the next 5 years. Thank you very much. I wish all our obstetricians are given support by Garbha Rakshahi in order to not to get into the medical legal problem with Cori amniotic fluid embolism, which you are making it as a regular diagnosis. Thank you very much for your patience here. Thank you. Over to Dr. Supriya.
Yes. Thank you, madam. Thank you very much for a wonderful talk and well in time, everything. So thank you so much.
Thank you.
Thank you. Thank you so much, madam, for being there. And thank you for your blessings always. Thank you, madam.
So now we'll move on to the last talk. So I think sir has joined.
Yes, Atul is there sitting.
Yes. Yes. So I'll just share his CV. May I request Dr. Charulata Bapai to introduce the speaker, Dr. Atul Ganatra, sir. Dr. Charu? Unmute yourself, Dr. Charu. Yeah.
Yes, Dr. Supriya, I was trying to unmute myself, but the host had muted me. So
Yes, welcome, Charu.
Yeah.
Thank you, Dr. Sneha, and heartiest congratulations on this fantastic ICOG course on such an important topic of emergency obstetrics. And such a pleasure to listen to Dr. Jayam Kannan, ma'am. Madam, it is always a pleasure to hear you. And now I move ahead to welcome and introduce our next speaker, none other than Dr. Atul Ganatra. We know he has been the past Vice President of FOXY West Zone 2020-2021. He has been the chairperson of the MTP Committee FOXY.
Charu, we can go on. I think it's late already.
Yeah, so he's a great gynecologist and endoscopic surgeon as well as an infertility specialist. And over to you, Dr. Ganatra, for your talk on jaundice in pregnancy.
Thank you. Can you see my screen?
Not
Zoom.
Yeah,
Zoom is
can
fine,
see
sir.
the Zoom window, but then.
Now?
Yes, sir. Yes.
So thank you very much to the entire team for having invited me here. This is my favorite slide when it comes to the women that we look after. Okay, you can tell the condition of a nation by looking at the status. And even today, we know that our women are still suffering. And I'm just... Hepatitis is a silent killer. WHO said that many years ago. There is a sharp rise in jaundice and typhoid cases this year. This is last year's slide. For every woman who dies in childbirth, 9 narrowly escape death. I think there are a lot of near misses. The topic is too vast. I'm going to try and concise as much as we can. Physiological changes in the liver during pregnancy, no change, SGOT, SGPT, bilirubin, prothrombin time. There is decreased gallbladder contractility, hemoglobin, uric acid levels, albumin, protein, and antithrombin concentrations, which means it becomes a hypercoagulable state. Blood volume and cardiac output rise by 35 to 50%. And phosphatase rises. Clotting factor changes. Pregnancy is a hypercoagulable state, and that is something that we need to remember. Jaundice is a characteristic of feature of liver disease. Signs and symptoms are indistinguishable between various forms. A differential diagnosis requires a serological test for a virus-specific diagnosis, and diagnosis is by biochemical assessment of the liver function. Causes of jaundice in pregnancy: hepatitis, acute viral, drug-induced, chronic hepatitis like B and C, autoimmune hepatitis, Wilson's disease, cirrhosis, Budd-Chiari syndrome, hemolytic anemia, very common in endemic areas. When a patient comes to us with dengue and malaria, we see marginally high levels. Post-hepatic causes, common bile stone, strictures, biliary parasitosis. And jaundice in pregnancy, the symptoms can be mixed with hyperemesis. Very often a patient comes to us with hyperemesis. There could be intrahepatic cholestasis, PIH, HELLP syndrome, and acute fatty liver. So these are our major issues which we need to sort out because they can be confusing, and I'm going to talk about them. I think if this one slide is seen by everybody and noticed by everybody, hemolytic uremic syndrome, we see a lot of TT and HUS in a tertiary care hospital. Immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, that's what I'm talking about, TT and HUS. APLA syndrome, DIC, we are a center of excellence for APLA syndrome. We've treated more than 1,050 patients of APLA. Patients come to us with repeated abortion failure, repeated IVF failures, DIC. Liver enzymes are increased in hepatitis and acute fatty liver. Miscellaneous causes could be SLE, drug-induced sepsis, abruption, amniotic fluid embolism. Dr. Jayan Kanan spoke beautifully on it. Cholestasis, appendicitis, dengue and malaria, which resemble hemolytic anemia. What is hepatitis? A viral infection, 5 types. A and E are typically caused by fecal-oral route, B, C, D, and D by blood and blood products and body fluids. B and C lead to chronic diseases in millions of people and are most common cause of liver cirrhosis and cancer. About 1 million people die as a result of viral hepatitis. Hepatitis in pregnancy, first trimester, hyperemesis, higher incidence of abortion, higher incidence of hypertensive disorders, and a higher incidence of postpartum hemorrhage in the second trimester. This is one slide. If you can just 1 minute, I'm just going to minimize my. Just 1 minute, please.
Dr. Atul, if you could raise your volume, the delegates will benefit.
Sure. I think that's the maximum. Am I not audible well?
There was a message in the chat box.
Yeah, now better, I think.
Okay. So if you can look at this slide will summarize my entire talk. The size of the virus, the incubation period, the transmission period of A and E, serological diagnosis, how do you do your, especially the hepatitis B part of it. You have to do an HPS-AG, we have to do a hepatitis E antigen. This decides the infectivity of it. Maximum infectivity is HPS-E, AG positive. Carrier state, none, 5 to 10%, 50%. Acute clinical forms, asymptomatic and fulminant. Sorry. I have seen fulminant hepatitis E when I was a resident. There was an endemic around my college. We had about 8 patients at one time with severe hepatitis E and pregnancy, and all of them died. So hepatitis E has to be treated very aggressively with supportive management. Chronic clinical forms you can see here. And chronic persistent hepatitis, chronic active hepatitis, cirrhosis of liver. Hepatitis A, it's a fecal-oral route. Most often can be managed conservatively. Nothing needs to be done. And there is no evidence that it causes birth defects. If a mother has HAV positive, we have to just give supportive therapy. The risk of transmission to the infant is very small. Antibodies are not transferred to the infected mothers. Pre-exposure prophylaxis, use of the inactivated hepatitis A vaccine, safe in pregnancy. HAV is not contraindication to breastfeeding. And post-exposure hepatitis, a single dose of 0.02 mg per ml given within 2 weeks of exposure. The vaccine is pretty common, pretty frequently used in Mumbai because of the endemic areas, especially the summer season that has already started. Clinical management, supportive treatment, most often nutrition, hydration, immunoglobulins if necessary. Avoid hepatotoxic substances and outpatient treatment. I have yet to see a bad hepatitis A patient, but they can present with encephalopathy sometimes. Severe malaise, asthenia, fulminant liver necrosis, and liver transplant. Prevention, we all know, boil your water, drink RO water, and we just have to be careful with the food that we have. HIV is inactivated by heating at 285 degrees centigrade for 1 minute, autoclaving, ultraviolet radiation, formalin, potassium permanganate, iodine, and chlorine. These are simple things that we need to do. Just boil your water, avoid eating outside food. Prognosis does not lead to chronic persistent hepatitis. Mortality, if it is very severe or if patient presents very late, symptoms are masked with hyperemesis, can be high, but the incidence is very, very low as compared to the other diseases. Global burden, disease due to hepatitis B and C can and cause cancer and cirrhosis liver accounts to about 2.7% of death. This is expected to increase further in the next 2 decades. An estimated 57% of liver cirrhosis and 78% of primary liver cancers are due to hepatitis B and or hepatitis C. And a total of 2 billion people have been infected with hepatitis B, and 600,000 people die every year as a result of hepatitis B and C. So I think this suffices that these two are more infectious and more dangerous than the HIV. It's just a fear of HIV that has been created in our mind. The B virus, sexual contact, mother-to-child transmission, blood-to-blood contact by unsafe injection practices, blood transfusion, equipment which is not sterile. Hepatitis C, almost the same, blood-to-blood contact by unsafe injection practices. More common in the Europe, blood transfusion, unsterile medical equipment. So I just said that HBV and HCV, that is B and C, are 5 times more infective than HIV. So what do we do? Promote vaccination against B, ensure needle and syringe programs, promote safe sex, ensure adequate sterilized medical equipment, promote vaccination and counseling services, raise awareness of hepatitis B and C. Treatment, again, active infection of B and C does not require any treatment. Combination of antiviral therapy has been the mainstay. Treatment remains poorly accessible and too costly in dose, and also a poor response to the treatment problems with adherence to intolerance of medication in low numbers of people on treatment. New and effective medicines are available but extremely expensive. Globally, this is the most common form of chronic hepatitis. Chronic carriers can continue to transmit the disease for many, many years. Infection, can occur in early childhood when it is symptomatic. Now, chronic HBV infection leads to increased risk of hepatitis, cirrhosis, and HCC. 2 billion people die worldwide. I think COVID did nothing. This is an endemic which is worse than COVID. So evidence suggests that the transmission of HBV to infants is common when mothers have an acute infection in the 3rd trimester, when they are chronic carriers of HBV infection and have positive results of HBe and HBV DNA. The risk of transmission is highest in which HBe, that is the envelope antigen, is positive. 90% of them can get infected, and approximately 25% of infected patients, infants, will become chronic carriers. So what do we do? Specific testing, very important. The surface antigen and antibodies, the core antigen and antibodies, and the E or the pre-core antigen and its antibodies. Infectivity, where it remains on surface, it comes into contact with for about 1 week without losing infectivity and can be affected by individuals' blood or infective material for weeks. Chronically infected individuals varies from highly infectious HBe positive to rarely infectious hepatitis B antibody. And the concentration is highest in blood, serum, wound exudates. And a moderate concentration is seen in semen and vaginal fluid. Can be detected in the serum for many weeks. The presence of HBs antigen indicates that the woman is potentially infectious. The presence of the E antigen is indicative of infectivity. Risk to the child is almost as high as 90%. So what do we do in these situations? Pre-exposure immunization is very important and recommended very highly. And furthermore, infants and adolescents not previously immunized should be vaccinated. All healthcare workers, including our residents, have to be periodically checked and vaccinated. Post-exposure immunization of hepatitis B immunoglobulin should be given to neonates and mothers of HBsAg positive. the HbIg, that is the immunoglobulin, has to be given within 2 hours. And the vaccination should be given within 1 hour to an HbSAg positive one. Now, this is the important point here, practical point. The HbIg may not be available immediately. So if you have a HbSAg positive patient, you must tell the husband that he must buy this injection and keep it in his own refrigerator, because the baby has to be given the immunoglobulin within 2 hours. Otherwise, there is a risk. So sometimes the hospital may not have it at all. HCV, highest prevalence is in Egypt. WHO estimates that about 3 to 4 million people are annually infected. Acute infection can lead to symptomatic hepatitis. In the pregnant population, the prevalence is estimated to be about 1%. Management is almost the same. Prevalence of HCV among pregnant women is 1%. Transfer of HCV infection to female infants may be twice as higher. Vertical transmission occurs in women who are RNA positive. The viral load of more than 100,000 copies are associated with an increased risk of vertical transmission. No evidence is available regarding LSCS versus vaginal delivery. Role of cesarean section to prevent vertical transmission is questionable. An elective cesarean section may be suggested in pregnant patients co-infected with HIV. HEV, one of the most dangerous hepatitis. Mortality is almost as high as 90 to 100% if they contract the disease and the patient comes late. Usually fecal-oral transmission. HIV is usually mild to moderate with a mortality of 0.4 to 4%. Pregnant patients may have a more severe illness with frequent fulminant hepatitis. Mortality rate raises progressively with term pregnancy with up to 20% mortality rate. And a maternal infection is associated with a high risk of fetal and neonatal morbidity and mortality. The cause of the increased severity of this hepatitis during pregnancy is unknown, but may be related to attenuated cellular immunity during pregnancy. The fulminant hepatitis may require liver transplantation. Even at Fortis, about once or twice a year, we come across about 4 or 5 patients with fulminant hepatitis. I have managed a surrogate with fulminant hepatitis E, and that is one patient in whom we have given 132 bottles of blood and blood products even after a hysterectomy was done. So this is a dangerous disease. One needs to be extremely cautious. And if a patient presents with jaundice, this is something that tests that we must do very aggressively. Transmission occurs in the intrapartum and peripartum. Significant vertical transmission of HEV RNA positive mothers up to 50%. Among women with symptomatic infection, the rate of transmission is 100%. The significant perinatal morbidity and mortality. Diagnosis by PCR, specific diagnosis is the key. Clinical management, no hyperimmune hepatitis E immunoglobulin is available. Supportive treatment has to be done. And if you feel that the patient has just about contracted jaundice and the fetus is viable, the earlier you can get the baby out, the better it is, because once DIC sets in, there is very little that you can do to these patients. Complications during pregnancy, fulminant HEV, premature deliveries with a high IMR of 33%. Mechanism of increased mortality is unknown. The related complications include gestational hypertension, PIH, proteinuria, and edema. HEV infection is largely prevented by public health measures, clean water supply. Pregnant women should avoid traveling to endemic areas, and they should avoid drinking outside water. HGV, I don't think we need to talk much about it. In 1966, this virus was identified after isolating a viral agent that led to a 3-week period of jaundice. I don't think we see many patients of this. Diagnosis is by lab studies. Type of hepatitis during pregnancy. I don't think we should say that patient can't afford it. We must do their tests. Type of hepatitis, acute chronic active and acute severe hepatitis. This is a slide which will tell you all about how diagnosis is to be made. A very important part here that we must remember, in hepatitis B, you see the SGOT, SGPT is in thousands, bilirubin is more than 5. Histopathology shows necrosis and potential transmission is there. Acute fatty liver, this is one thing that confuses HELP, because very often a patient who comes to us with PIH, we don't know whether it is HELP or AFLP. We've seen very, very bad patients of AFLP. We must remember that they have borderline levels of high bilirubin and SGOT, SGPT. The most important feature which differentiates with them then is an increased uric acid level and hypoglycemia. If a patient has low sugar levels, you are looking at acute fatty liver. This is one slide that gives you a complete differential diagnosis. Intrahepatic cholestasis, less than 300, less than 5, dilated bile canaliculi, pruritus, very, very important. And this is where you can give udiliv to our patients. HELP, more than 500, less than 5, periportal necrosis, hypertension, edema, thrombocyte. So this is the most important. The last three ones, one which is uric acid, is what takes away the diagnosis. In pregnancy, established type by serological test, institute appropriate isolation and precautions, activity determined by tolerance, diet, patient preference, antiemetic, you can give phenothiazine, steroids not indicated. Immunoprophylaxis of the infant if hepatitis B is present, the immunoglobulin has to be given immediately. Symptoms, I think all of us know, GI symptoms, itching, liver function severely abnormal, late cases, renal failure and coagulopathy. Guidelines: protect the liver, prevention of encephalopathy, prevent DIC, prevent hepatorenal syndrome. Ideally, these patients, if OTPT levels are high, should be admitted, and a combined gastro person should manage this patient with you. 6 responsibilities for perinatal hepatitis. I think all of us must remember this. Assure identification of all HbSAg positive persons. Assure all exposed infants receive the immunoglobulin. Prevention of perinatal transmission. Assure that all susceptible households and sexual contacts are vaccinated. Assure completion of 3 doses of hepatitis vaccine post-vaccination for exposed infants. Conduct surveillance, quality assurance, and outreach to improve the program and reduce the morbidity and mortality. Taking lamivudine before pregnancy in a patient with hepatitis can reduce the load and the viral load of patients. This is something that is indicated. Give the immunoglobulin fast. Give the vaccination as early as possible. Mode of delivery does not influence the rate of transmission. Infection prior to delivery has been shown to occur in about 33%. Cesarean is suggested when co-infected with HIV. Reduces the MF transmission by about 60%. Again, this is something that all of us need to remember. Symptoms, prognosis, cause, and times of onset. This is a busy slide, but I think this predominantly, I have made this slide for our postgraduate students as to what you must do and how do you diagnose these situations. True prevention is not waiting for bad things to happen. It's preventing things from happening in the first place. Treatment without prevention is simply unsustainable. Thank you very much.
Thank you, Dr. Ganatra, for making such a difficult topic look quite simple the way you have presented it. Such a crisp presentation, and thank you for telling us that prevention is better than cure. Over to you, Dr. Supriya.
Thank you. Thank you very much. Now we have come to the end of this ICOG Day 2, and all the talks have been over. And brilliant talk, Dr. Atul sir. You also took out time from your busy routine. So thank you so much. Over to you, Sneha ma'am.
Yeah, thank you so much, Dr. Ganatra. That was excellent talk, very informative, in-depth, and still you make it very comprehensive as well. Thank you so much for taking time from your busy schedule. And without investing much time, we go ahead with the post link, which is a part of this protocol. So Nilima, Poonam, can we have the link, please? Yeah, so we can see the link in the chat box already. I think Gauri, you need to check the link. Somebody is saying it is the wrong link.
करेक्ट लिंक है मैंने फिर से शेयर करी है
Yeah, thank you. I think the time is up.
चलो शेयर द आंसर शीट
Gauri, is the time up? You can share.
Yes, ma'am.
Yeah, so
Yes.
you can share the answers.
Hello, ma'am. I've shared the screen.
Yeah, you can, if you can, please magnify a bit. Yeah, thank you. So I'm just starting to read the answers. First, anaphylaxis is a severe allergic reaction that can occur during pregnancy. What is the prevalence of anaphylaxis in pregnant women? And the correct answer is 1 in 500 pregnancy. When managing anaphylaxis in a pregnant woman, which medication should be administered first? So the answer is epinephrine. How long should a pregnant woman experience anaphylaxis be observed in a healthcare facility? So 24 hours, that is the correct answer. Which medication can be used as an adjuvant therapy for anaphylaxis in pregnant women? The correct answer is omalizumab. Omalizumab. Yeah, fifth one now. Which of the following measures should be taken in the management of anaphylaxis during pregnancy? All of the above. That is the correct answer. That means place the patient in a supine position, administer oxygen, maintain intravenous access. So all of the above. The incidence of abruptio placentae is, the correct answer is 1% of all pregnancies. The risk factors for abruptio placentae include all except. So first is gestational diabetes, preeclampsia, preterm PROM. So except, the correct answer is Down syndrome. Has nothing to do with abruptio placentae. The most common cause of DIC in obstetrics, the correct answer is abruptio placentae. Recurrence risk in future pregnancy after first abruptio placentae is tenfold. It increases by tenfold. That is the correct answer. In placenta accreta spectrum, severity of morbidity is driven mostly by the placental adhesion to the scar. That is the correct answer. It's not the placental invasion, fetal presentation, or number of previous seizure, but in fact the placental adhesion to the scar. Which one contributes for the highest prevalence of placenta accreta spectrum? The previous cesarean section. Which ultrasound picture describes the REL sign in placenta accreta spectrum? A plus B plus C, or that is how the correct answer is. The next one is in a massive hemorrhage during placenta accreta spectrum surgery, what is the best guidance for correction of coagulopathy? The rotational thromboelastometry. All of you have seen, almost 3 speakers have talked about this. Rotational thromboelastometry. What is the type of shock in inversion of uterus besides hemorrhagic? So neurogenic, that is the correct answer. What type of shock is anaphylactic shock? It is extracardiac shock. The correct answer is extracardiac. Obstetrics SOFA scoring system is applicable to septic shock. That is the correct answer. Peripartum cardiomyopathy is seen which period of pregnancy? That is last trimester and 5 months post-delivery. That is the correct answer. Why perimortem cesarean section is done during resuscitation of the mother? It helps in better resuscitation. That's the reason Dr. Jayam Karan also said that it is resuscitative hysterotomy. Which sickle crisis is common in pregnancy? That is vaso-occlusive painful crisis. Next one, which out of these is the genetic defect in sickle cell disease? The substitution of valine by glutamic acid in the beta globulin chain of hemoglobin. That is the defect in the sickle cell disease. Which is the confirmatory test for sickle cell anemia? Hemoglobin electrophoresis, naturally, to diagnose any hemoglobinopathy. If both parents are AS type of sickling, which test should be done as prenatal testing? And that is chorion-villus biopsy for early pregnancy, definitely the cordocentesis for late pregnancy. All the following are associated with placenta previa except gestational diabetes. All the following are associated with placenta previa except gestational diabetes. That is what the correct answer is. Low-lying placenta is defined as placental age less than 2 centimeters from the internal os. Outpatient management of women with placenta previa is safe till what time? Till the active bleeding episode occurs. That is what it is labeled here. The following conditions are associated with placenta previa except obstructed labor. That is the correct answer. Transvaginal sonography is contraindicated in placenta previa at 12 weeks. It is false. In fact, that is the confirmatory diagnostic test. What is the most common cause of acute hemolytic transfusion reaction? That is the ABO incompatibility. Transfusion-related acute lung injury TRALI is characterized by dyspnea, hypoxia, non-cardiogenic pulmonary edema. And the last one, which blood component is most commonly associated with transfusion-related allergic reaction? The answer is fresh frozen plasma. I think all the answers are very, very clear and there is no conflicts here. So I think that should be all. Yeah, so there's no query or no other message here. So over to Dr. Parag for your comments and to conclude.
Thank you, Sneha. Good evening. And on behalf of ICOG, I would like to thank all of you for being here today and waiting so long, attending all the sessions. Sneha, very well selected topics and the speakers were excellent. Supriya, excellent job. Sitting in one place of more than 4 hours is a task in itself. And thank you to all the speakers, the chairpersons, and of course, all the delegates for whom the ICOG is bringing these certificate courses. So tomorrow is the last day, and don't forget to log in at 4 o'clock for the pre-test. And of course, tomorrow we'll have some more seniors who will be deliberating in different aspects of emergency obstetrics. Thank you and good night.
Thank you so much. I thank all the faculties, chairperson, and everybody who is logged in. Thank you so much once again. Thank you, Parag.
Thank you. Thank you, Sneha ma'am.